Hello and welcome to day 2 of our 2-day virtual public meeting where we are exploring and trying to better understand the current landscape of fatal overdoses in the United States and thus inform product development and public health interventions. My name is Susan Winkler and I have the honor of serving as the Chief Executive Officer for the Reagan-Udall Foundation for the FDA, and we are pleased to be partnering with the agency on this activity. I have just a few housekeeping items as we kick off the meeting. Because of the size of the meeting, attendee cameras and microphones will remain off throughout the event. The slides from both yesterday and today are already posted on the Foundation website. So if you have any trouble seeing those or you want to put them up on a big screen, you should be able to pull them up and look at them as our speakers walk through them. We have a few moments in each session to address audience questions, so please submit your questions and comments through the Q&A function. And finally, we are recording the meeting and plan to post the recording along with the transcript on the Foundation website next week. And that should help. We had a little bit of audio trouble yesterday, but we understand that the recording is clear. And so if you missed something yesterday, we'll direct you to the recording as it's available next week. So let's talk about our time together today. In just a moment, we will hear from research, public health, and policy experts about novel approaches to preventing overdose death. Then we will learn from FDA about regulatory considerations for developing opioid overdose management products. We'll gather researchers, clinicians, and those working in the community to explore considerations for developing new products for overdose management. And finally, we have a panel discussion on the future and thinking through where do we go from here. You'll note on the agenda that we don't have any breaks today, so we understand if you need to step away and come back, but we hope that you will remain engaged throughout the entire session. So with that, I want us to turn right away to our first session for day 2, where we want to explore novel approaches to preventing overdose deaths. To begin our presentations today, we will hear from Mary Silla, who is the Director of Overdose Prevention Policy and Strategy at the National Harm Reduction Coalition. Mary, if you would step up, as we say, step up to the microphone. I see you on screen. I'll let you take it away. You're still muted.
Thank you, Susan. Let me take control of the slides. There we go. Thanks, Susan, and thanks to the Reagan-Udall Foundation for this opportunity. Today, I'll be talking about novel approaches to overdose prevention. I'm going to highlight approaches that I think will have the greatest impact on the overdose epidemic, as well as those that are getting attention nationally for other reasons. What I want you to take away from my presentation is that while there are some different models and intervention, the work with the greatest promise to reduce overdose deaths in the short term is being done by community-based organizations that work for and with people who use drugs. And I work for one of those organizations, the National Harm Reduction Coalition. The National Harm Reduction Coalition creates spaces for dialogue and action that help heal the harms caused by racialized drug policies. We engage in a broad spectrum of work in service of the harm reduction community, from policy and advocacy to direct service overdose prevention on the streets of San Francisco. We provide technical assistance to safe syringe programs through a contract with the CDC and convene conferences and produce resources to support harm reduction throughout the US. I'd like to acknowledge the setting and presumed audience of this presentation. I understand that the framing of this meeting and the FDA's purview may center pharmacological answers to the overdose death crisis in the US, and that industry's interest is in producing novel medications and devices for the solution. But from the community's perspective, the scientists have done their work. We have an opioid antagonist, naloxone, that reverses natural and synthetic opioid overdoses safely and effectively. The reason we continue to see the rise in opioid overdose deaths is that naloxone is simply not easily and cheaply accessible to people who are at risk of overdose, people who use drugs. And the way to reach those people is harm reduction. Fortunately, engaging harm reduction is one of the FDA's 4 priorities, and probably the reason I'm speaking to you now. Now, I'm not sure we have a common definition of harm reduction, but one principle I hope we can agree on is this: harm reduction is non-judgmental, non-coercive, and non-punitive. It meets people where they are and recognizes that change is hard and that the best approach to supporting healthier choices is supporting all decisions along the stages of change continuum. Since the best approach to overdose prevention is to get naloxone into the hands of people who use drugs, I'm going to start by talking about a few ways to increase naloxone access for people who use drugs. Now, there's a lot going on in this slide, but I'm going to walk you through all the references. In the upper left-hand corner, we have Next Distro. Next Distro is a nonprofit organization based in New York that mails harm reduction supplies all over the country. They mail naloxone and syringes to people who can use them where they live, and so they can practice harm reduction. Below that, we have a poster for the SRO project, a sub-project of the Drug Overdose and Prevention Education, or DOPE project, whose logo is next to it. The SRO project provides naloxone and education in single-room occupancy housing in San Francisco, and as you can see, it's a peer-based program. The sign says, if you want naloxone and training, you can talk to Robert. The DOPE project has been operating since the 90s to provide overdose prevention in San Francisco streets. The DOPE project and the SRO project are both projects of the National Harm Reduction Coalition. The colorful poster on the right-hand side, entitled Impact Exchange, is one of the first harm reduction vending machine programs in the country from Track B out of Las Vegas, Nevada. The vending machine model is an exciting new model that allows people to access harm reduction supplies without stigma and also in remote locations. Down below on the left, you'll see vending machines are also dispensing free medications in jails across the country, here in a reference to a program in North Carolina. There are also machines upon exit of the LA County Jail and throughout Michigan, as an example. Naloxone access upon release from incarceration is very important because the risk of overdose at that time is much higher because during incarceration, opioid tolerance likely declines. Next to the DOPE project logo is just one example of the many safe syringe programs that operate across the country. This one, Access Point, Georgia, providing safe syringes and naloxone in Athens. And down in the lower right of the screen is the PubMed title of an article by some of my favorite researchers that makes the point that safe syringe programs such as Access Point are the best place to provide people access to naloxone if we want to prevent overdose deaths. If we want to get naloxone to people who use drugs, we need safe syringe programs, which are often the only point of contact folks who use drugs have with any sort of health services regularly. And we need for those programs to have access to plenty of naloxone. Tucked in the middle of this slide is the DanceSafe logo. DanceSafe is an organization that provides drug education and checking services at festivals and other party venues where people may be using drugs. That was a whirlwind tour of a bunch of nonprofit programs providing access to naloxone and other harm reduction supplies that I believe are doing the work that is most useful in preventing overdoses currently, meeting people who use drugs where they are. With more resources, these types of programs could be doing even more. And when we're talking about novel projects to prevent overdose, I can't help but mention overdose prevention centers. Overdose prevention centers are places where people can consume pre-obtained drugs with overdose prevention staff and supplies at hand to reduce the risk of overdose. On this slide, I've included the logo of On Point in New York, which has been operating for over a year, reversing overdoses, and is led by Sam Rivera. It's a remarkable project that is setting the standard currently. In the lower left corner is a screenshot from a news report from just last week when a contingent of policymakers and community members from San Francisco visited New York and the On Point location to see what it looks like to run such a program. San Francisco supervisors and the mayor are very interested in this model. In the lower right-hand corner is the logo of the Rhode Island Overdose Prevention Center, the first in the country that is legally authorized by state statute. And in the middle of the right-hand side is a reference to the litigation in the Third Circuit, United States versus Safe House. Safe House has been proposing to open and run an overdose prevention center for some years now. The litigation will determine whether the Department of Justice considers overdose prevention centers illegal under what is colloquially known as the crack house statute. It's the hope and expectation of the community at this point that a settlement will be reached to allow Safe House and other overdose prevention centers to operate without fear of federal prosecution under the crack house statute. And finally, as the caption of this slide, legislation to authorize overdose prevention centers is pending in Colorado, Connecticut, Illinois, Maryland, Massachusetts, New Mexico, and Vermont. With all of this activity, overdose prevention centers are clearly the intervention to watch in 2023. Turning back to effective ways to reduce overdose deaths and get naloxone in the hands of more people, I want to talk about novel approaches to reducing the cost of naloxone to consumers. The most exciting way is a low-cost naloxone program operated by Remedy Alliance. Remedy Alliance for the People provides injectable naloxone at very low cost to harm reduction programs throughout the country. They've been doing so since last year when, as Commissioner Califf mentioned yesterday, the FDA issued an official exemption and exclusion from requirements of the Drug Supply Chain Security Act, as captioned there in the center of the slide, in September of last year. This allows harm reduction programs and suppliers to buy naloxone wholesale and distribute it without having to comply with burdensome tracing, licensing, and reporting requirements that are otherwise necessary for pharmaceutical distribution. This exemption is valid while we are in the opioid public health emergency. I can't say enough of how proud I am to know Maya Doe-Simpkins, Eliza Wheeler, and Nab Dasgupta, who have led this work, and how much I appreciate their willingness to administer what is a complicated and burdensome project at this point. They are saving lives every day at low or no cost to struggling harm reduction programs. And while we're talking about price and cost, I must mention over-the-counter naloxone. As people on this call are likely aware, the FDA has approved the concept of over-the-counter naloxone, and Emergent BioSolutions nasal Narcan seems poised to be the first approved OTC naloxone product. An exciting development in theory, the actual impact on access to naloxone for people at high risk of overdose remains to be seen, and will be influenced by things we don't know yet, including the product's price, what an OTC product's impact will be on insurance coverage of naloxone products, and whether pharmacies will be willing to carry and sell OTC naloxone. I'm reminded of a research article on syringe sales by pharmacists that said that some pharmacists didn't know they could sell syringes for the purpose of harm reduction, and even those who did said they would not because they were not interested in attracting customers who use drugs. And speaking of pharmacies and people who use drugs, I want to talk about another important pharmaceutical-based way to reduce overdose deaths. We need to lower barriers to treatment. People who are willing and able to engage in drug treatment are far less vulnerable to overdose. But unfortunately, given the barriers to treatment in the US, it is often easier to access illegal drugs than it is to access medications for treatment. This must change. The two primary medications for opioid use disorder, buprenorphine and methadone, should be easily prescribed and easy to get. We have seen a reduction in the barriers to prescribing of buprenorphine recently with the MAT Act, and hopefully more providers will engage in prescribing it as a result. But methadone is still a mess. The anachronistic opioid treatment centers model increases barrier and stigma to receiving this medication, and the disparity between the process for being treated with methadone and buprenorphine is indefensible. Rather than lay out all the problems of the model, I'll refer you to the Methadone Manifesto of the Urban Survivors Union and the recently released documentary, Swallow This, available for rent online. Fortunately, change may be on the horizon. Just last week, Senator Markey of Massachusetts introduced a bill to expand the take-home prescribing of methadone through pharmacies, as it is dispensed in Australia, Canada, and Great Britain. In conjunction with Senate Bill 644, Senator Markey and a bipartisan group of senators sent a letter to HHS and SAMHSA asking not only for COVID-era rules on take-home methadone to be made permanent, but for further action to make methadone available through pharmacies. Finally, I want to mention drug checking. In order to detect fentanyl and other unanticipated substances, drug checking has become widespread through the use of fentanyl test strips. You can order them on Amazon. Federal grantees can use federal funding to purchase them. More expensively, spectrometers can analyze drugs to see if they are what we think they are. Universities and large nonprofits in San Francisco have spectrometers. From the community perspective, drug checking may be useful if people have access to the tools to check their drugs. And as a side note, many states are amending their drug paraphernalia laws to permit drug checking with fentanyl test strips in an attempt to do something about overdose. But testing drugs is not a great solution to the problem of fentanyl overdose because while drugs are illegal, checking drugs will remain a risky proposition for people who use drugs. If we are actively concerned about what is in the drug supply in the US, the better harm reduction public health response would be to maintain a stable supply and open avenues to treatment. In conclusion, I believe we have the tools we need to substantially reduce overdose deaths: naloxone, methadone, and buprenorphine. We simply need to get those tools into the hands of people who use drugs and to build social support systems for their use, including reducing the stigma of drug use. And I'll end as I began. I believe the work with the greatest promise to reduce overdose deaths in the short term is being done by community-based organizations that work for and with people who use drugs. Thanks for your attention, and I look forward to the conversation to follow.
Mary, thank you. You helped us connect. We concluded yesterday's workshop with an admonition to increase access to naloxone, and the phrasing was made perhaps even something about putting it everywhere. You've helped provide some texture to that everywhere. What does that mean, and some options for it, and then expanded our conversation to think about medications for treating opioid use disorder and other options. So thank you for that stage setting, which then allows us to turn to a broader panel conversation where I'm going to invite a number of, in fact, 4 additional people to come to our virtual stage and engage in a conversation about novel approaches. So joining Mary, we have Dr. Mark Lasician, who's Deputy Chief Medical Officer at Vancouver Coastal Health, Dr. Jermaine Jones, who is Associate Professor of Clinical Neurobiology at Columbia University Department of Psychiatry, Emmanuel Sferios, who is the founder of Dance Safe, and you've already gotten a shout out from the presentation, and Captain Jennifer Fan, who is the Acting Director of the Center for Substance Abuse Prevention at SAMHSA, which we use as the short name for the Substance Abuse and Mental Health Services Administration. So thank you all for coming to our stage here and joining us for the conversation. I want to turn first, Dr. Lasician, I'm going to turn actually to each of our new voices, and then we'll turn to more of a conversation. But would you jump in? What lessons from the Canadian context should we be considering here in the United States?
Yeah, thanks so much for having me. I would agree with Mary that naloxone access is super important. We started our take-home naloxone program here in British Columbia in 2012 and have massively expanded it in the context of the overdose emergency, which has been declared here. We have over 2,000 sites providing free take-home naloxone, and that's including pharmacy sites that are providing that free. But ultimately, people need to have somebody there to provide naloxone if they're having an overdose, and people do use drugs alone, and sometimes the people they're using drugs with, are not able to respond in a timely manner. And so, once we provided people with naloxone and provided them with training, people who use drugs and people who supported them in the community set up pop-up overdose prevention sites in British Columbia back in 2015, 2016, because of course they had the naloxone, they had the ability to use it. All they needed to provide people was a chair and a table to use their drugs. And of course that was considered illegal initially, and there was a big debate about it. We operate inside the the first supervised consumption site in Canada, and we were struggling at that time to open new supervised consumption sites with the regulations that were in place. And luckily, the government of BC at that time gave permission to health authorities to operate overdose prevention sites. And within the years that followed, we've massively scaled up that that intervention as well. And now there are about 40 overdose prevention sites operating across BC, and they've allowed us to really innovate in the space of supervised consumption. We provide sites that are for women only. We provide mobile sites. We provide sites on hospital grounds, all places where overdose prevention services are needed, in addition to the wider community. They've also provided a great opportunity to provide drug checking services. So now we have over 40 sites in British Columbia that are providing drug checking services with test strips and spectrometers and confirmatory testing by laboratories. But, as Mary mentioned, these things don't address the underlying problem here, which is the toxicity of the drug supply. And so now we're moving into a new phase of the response, which is about prescribing safer alternatives to the drug supply. And doctors in BC have been empowered to prescribe a limited number of safer alternatives to the drug supply. And we're advocating for that list of medications to be expanded and also, to be able to be provided to people without prescriptions. But currently that's not possible. But so that's really where we're headed now. Naloxone is definitely needed. Overdose prevention sites are definitely needed. Drug checking is needed. But ultimately, what's needed is something that will address the toxicity in the drug supply. And that's by providing people with safe pharmaceutical alternatives.
Really intriguing idea and opportunity for all of us to think about in expanding and exploring precisely where we might go in the conversation. But it strikes me that tie then to what we were talking about yesterday in understanding the changes in the illicit drug supply and the challenges created. I think you're saying come at it from a different direction, and let's use a supply that we know would be more safe. So I'm confident we'll want to come back to that and have a little more conversation on that throughout here. But I want to turn next to Dr. Jones. Specific question for you about what should researchers and members of the community consider when they're building a naloxone distribution program, especially thinking about education and outreach?
So thanks for that. I think that's a great question. So I think our research at Columbia really shows that there's a number of ways that you can get involved in naloxone distribution. And I think the things that these programs should consider is who is their target population for getting naloxone to. Our studies show that people who use substances, particularly opioids, already have a significant baseline knowledge as far as recognizing opioid overdose and maybe even have had experience with using naloxone. So for those programs, if you know that that's your audience, or if you have certain limitations about who can provide an in-depth naloxone training, how long is your clientele going to stick around for a long training? You may not need a training. Just give them naloxone. So you can get naloxone to as many people as possible. If you're dealing with individuals who may be less familiar, in order to increase the likelihood that they feel empowered and confident in using naloxone, you may need to give those individuals a little bit more background education and a little bit more support, because you want them to feel confident in being able to recognize an overdose and being able to use naloxone. Our research also shows that individuals understanding what their local laws are and your protections that you have in case you encounter an overdose is really important, maybe even more important than how to recognize an overdose. One of the decisions in the decision factors that individuals have to make when they're determined in this overdose scenario is often, what are the protections that I have if I call 911, if I administer naloxone? So knowledge of state laws and or laws that are particular to your jurisdictions are also very important.
And Dr. Jones, that is helpful and additional insight. We heard yesterday from a great individual who was speaking to, she said that she waits to call 911 until the individual has, is in a place where they can contribute to the decision about whether or not that should happen. And thank you for the tie back in meeting people where they are in naloxone education versus assuming that you have a naive audience. Emmanuel, I want to turn to you next. And you've been engaged in harm reduction work for a number of years. And what are some of the most effective strategies you've seen, and how might those relate to what Mary presented to us in the slides?
Thank you. 24 years now. It's crazy, and I'm so happy to see how far we've come in 24 years. Unfortunately, it took a fentanyl crisis to get us here. I do want to thank Mary and Mark for saying something that's very important, which is that drug checking is not going to get us out of this crisis. As the pioneer of drug checking back in the 90s, when young people started dying from counterfeit ecstasy tablets, I always said that I started DanceSafe to make DanceSafe obsolete, because if we did have a safe, regulated supply, we wouldn't need private charities to be offering the service. But unfortunately, we do currently. I also want to echo paraphernalia laws as getting in the way, but I do want to say there's only a few ways in which they get in the way. It prevent state and county government health departments from providing drug checking services. There's been no arrests in the last 24 years of anyone for solely possessing a drug checking kit. We've been shipping them, over 1 million now the last couple decades to every state in the country. Doesn't even stop smoke shops from selling them. It's just these laws are outdated. The fear, lawyers advise the DAs not to do it, or programs not to do it. So we do need to get those overturned. And then access to drug checking programs and education is really hampered by prohibition. Also, just simple decriminalization I want to advocate for is so important. When a user no longer fears getting arrested for their personal drug use, because that's all decriminalization is. It's still illegal to sell, manufacture, but when you're possessing drugs for yourself and you no longer have fear that you're going to be arrested, that opens up the public space for dialogue and services. You now can talk to your teachers, your doctors, people who you're not afraid to speak to. You're less likely to use alone because you're not going to get arrested. So decriminalization is really important. I also want to bring something up that's sort of came up recently. The laws allowing naloxone to be distributed to programs for distribution is great, but we also need the ability to distribute naloxone directly to consumers without prescription. DanceSafe receives about 200 to 250 orders a day from people who use drugs across this country. Now, most of those folks are recreational users, not people with using opioids daily, although some are now that we've made it into the fentanyl. I'll talk about that in a second. But still, for accidental overdoses from contaminated or adulterated drugs, getting naloxone into the hands of all of these people would be extraordinarily helpful. So just being able to sell them even at cost directly online would be extremely important. A little bit about our fentanyl test strip program. We've introduced a new fentanyl test strip, worked with the manufacturer to develop one that works better, that does not produce false positives like the earlier ones did. And we now have 13 state health departments, dozens of county health departments, and hundreds of other social service agencies now who are buying our strips. My daily activity seems to be running a shipping center out of my home. So that's a grand success. The fentanyl strips are only really useful, I guess, these days anymore for people using non-opioids. Most people now recognize that opioids are primarily fentanyl. But for whatever reason, there's the fentanyls. I like using that plural because there's the analogs are creeping into the other drugs, and so drug checking is still useful, and it also just helps as an educational point. It's what I learned when I started DanceSafe with the ecstasy, the chemical that we use to test ecstasy tablets, is that when you have a service, no matter how effective it might be, it actually provides a tactile physical reinforcement for the education. If we just went out there and told people, hey, your pills are adulterated, you got to be careful, but there is no way for anyone to check, it goes in one ear and right out the other. But the fact that you have a tool, it really provides a psychological, overcomes that barrier to understanding, wow, this really is a thing, and I really do need to check my drugs first. So just the educational component of fentanyl test strips is very important. I also wanted to bring up something that I haven't heard a lot discussed about daily opioid management, and that is helping daily opioid users understand the safest way to use opioids daily. I don't think anyone here buys into that, all of that judgment and stigma around naloxone parties, and believes that people who are using opioids daily are chasing euphoria and that it's their own fault, et cetera. But there's some interesting scientific studies that show that overdoses are somewhat related to not just the dose, but the time of day and the familiarity of the environment. They've actually given opioids in animal studies, and if they move the animals to a different colored room, they will overdose. So there's something about our opioid receptors upregulating and downregulating based upon expectation and familiarity. So I will admit right now, because 2 months ago I was diagnosed with a rare autoimmune disorder that's painful and debilitating called myositis, where my immune system is attacking my muscles. And for the last 2 months, have been taking 30 milligrams of Oxy once or twice a day within a short window in the evenings. And I can miss a day with no withdrawal symptoms. So taking the drug the same time every day, as best as possible, the same dose, is very important for preventing overdoses. It's the chaotic use where you're taking at random times every day. And unfortunately, fentanyl is shorter acting than heroin, and people have to redose more often, and there's challenges around that. So I really advocate for medication-assisted treatment, and not just buprenorphine and morphine, but heroin and maybe opiate of choice medication, as long as it's not take-home where people can sell it to their friends. If it's in a clinic, and these programs are available in Europe, they have really done the most to not only prevent opioids, but also shrink the illicit market of opioids. So there's fewer new users, because who would buy unknown opioids from a dealer when you can get known opioids through a program?
Mm-hmm.
Yeah, thank you.
That's a nice connection to the idea of continuing to understand the use and opportunities that the novel approach idea, as well as tying back to the confirming a reliable supply of legitimate product. I want to close us out with new voices, and then we're going to turn to the conversation in our next question. Final new voice on our screen, Dr. Fan, Captain Fan, I should say. We know that there have been innovative pilot programs around the country to increase the availability of naloxone. Mary mentioned some of those with the vending machine and other components. Tell us more about what SAMHSA has done to support scaling up those distribution efforts and offering technical assistance.
Yeah, SAMHSA has quite a number of programs. I guess first and foremost, in regards to supporting the naloxone distribution and trying to get naloxone into the people who need naloxone. We have the naloxone grant programs. The PDO was it the grants for preventing prescription drugs, opioid overdose grants, or something like that. Supplying communities to providing funds so that they can go ahead and purchase naloxone. We have the FR Care grants that has a two-part component. One is for purchasing naloxone, but the other component is also education for first responders and key community stakeholders on overdose in general and naloxone and how to use and hopefully combat that stigma that's out there. We have our block grant. Our block grant allows purchase of naloxone along with education and trying to prevent that overdose piece. But more importantly, we have these harm reduction grants, and they're pretty new grants, and they're less than a year. And so there are some programs that are still revving up, but there are some programs that are, very innovative in what they're doing. Like Mary had said, and other panelists have said, trying to meet people where they are. And I think that's key, and that's key to access. We see vending machines as one, mobile vans going to areas where the populations are in need, and not just in terms of access to naloxone, but they also provide services such as HIV, hepatitis C testing, connections to certain services that connect to social determinants of health, housing, access to even wound care kits. And I know and not just fentanyl, but also with adulterated supply with xylazine and some of the tissue wounds that they need. Right, exactly. They need access to some of the other stuff that's around, so harm reduction, naloxone is one piece, but there's another piece to it. And more importantly, these sites can be access or linkages to treatment. And so we're trying to meet the community and trying to provide what they need. So looking at the whole person care. We also do have one more thing.
That's all right.
We do have technical assistance centers. The PCTC, which is the prevention side, they may help in terms of prevention, but they're accessible through the community webinars, all of that. But more importantly, we do have a harm reduction technical assistance center that I believe it's a CDC SAMHSA collaboration, so the public can access programs, webinars, and technical assistance from the center, but it also provides technical assistance to our grantees for harm reduction as well.
I'm glad that we had you give that last point, because that's got to be an important one for sharing lessons learned and helping to make sure if you have a good idea in one grantee that it's shared across the others. Excellent. And
I think that brings up a really good important point, because we're actually talking to states right now. We did a learning communities with the 50 states and territories, and I think we're proceeding on with trying to do a policy academy. But the idea of sharing, because as Mary said, communities, that's where all the work is being done. A lot of innovation. And so to be able to share those ideas across states, to see what they're doing, what works, what doesn't work, what the challenges are, and that two-way dialogue, I think is very important.
Fabulous. And as we continue the dialogue, the next question I'm going to put to all of you, and so whoever unmutes first or raises their hand, you're going to be first to jump in the queue. This is a question I asked yesterday, and I'm going to ask it again today to see if we can gather any more information. And that's, have you heard of any experiences where someone had an overdose management product, so had naloxone at hand, but either they weren't able to use the product or they found the product didn't work as they expected it to. Anybody with a experience there, or something that you've heard in that space? Dr. Jones.
Sure, I'll start. So we have had experience where individuals had access to naloxone, encountered an overdose, were able to accurately identify it as an opioid overdose, but had reservations about administering naloxone that precluded them from using. We particularly found this to be prominent among women when the overdose victim was a male, and a male that they didn't know. Particularly because there was some concern about how the individual may react if the naloxone precipitated withdrawal, or if the overdose victim doesn't know that they overdosed, right? The last thing that they remembered was feeling a pretty good drug effect, and then all of a sudden they may come out of it in withdrawal. But there, individuals who have had naloxone administered to them do know that precipitated withdrawal is a possibility, so it can can cause some reservation. And I think that was one of the things that we found, was that in certain situations, if there was a female who didn't have support of someone else, and the overdose victim wasn't someone that they knew, then there was some reservation about using naloxone.
Okay, that's helpful and gives us a different example from some that we were discussing yesterday. Dr. Lasishin. Yep, sorry, go ahead, Dr. Jones.
Sorry, I'll just follow up very briefly. I think that's one of the things that we consider took away from the study as potential ways to improve this. The idea of overdose education and naloxone distribution was to make naloxone more tolerable. Because there is some concern about precipitated withdrawal.
Yeah, and one of the thoughts raised yesterday was about titratable, right, in using the injection versus the intranasal administration, and opportunity to adjust there. Dr. Lasishin.
Well, I was going to say that, in general, naloxone does work as an antagonist against opioids, but, unfortunately, with the toxic drug supply, it's not just opioids that people are being exposed to. And so, since about 2019 in British Columbia, we've seen benzodiazepines and benzodiazepine analogs contaminating the drug supply, to the point now that about 30 to 40% of all opioids, that are tested through our drug checking programs are positive for benzodiazepines and benzodiazepine analogs. We're starting to see xylazine, like has been mentioned here too. And of course, naloxone doesn't work against these chemicals. And, so at our overdose prevention sites, it's not infrequent that people, will have their breathing restored by naloxone, but they spend, hours in need of support and care because they're sedated. These drugs are amnestic. And, if people weren't at the overdose prevention site, it would subject them to risks of violence, sexual violence, theft, and things like this. So, overdoses have become very complicated to manage. And, they can be managed at overdose prevention sites, but it takes a lot of time, and, that locks up a booth from somebody else being able to use the service as well. And so it's complicated. And of course, if somebody's not at a site like that, it's very difficult for people to manage that. So that's been a real issue as well. I think also the issue of people being afraid to call 911 for fear of police attendance. We have had a policy in BC that police will not attend overdoses unless there's some other risk identified, but people are still afraid to call. And, recently we're entering into a 3-year exemption to decriminalize possession of drugs here in British Columbia. And we hope that will help people be able to, attend harm reduction sites and call first responders to help them when they can't manage their overdoses.
I want to put a fine point on that. So then you're also observing that while we have the opportunity to reverse the opioid, there's not a current intervention to reverse the benzodiazepine.
Yeah, not that can be applied in the community. There is an antidote drug that can be used in emergency room settings, but often it is not used because it can induce seizures, and then you sort of cause more harm with the medicine, but it's not practical to use in the community.
Okay, really helpful. Anyone else want to chime in on this question about the experiences with an overdose management product that they either didn't use or found it didn't work as expected? Okay, then let's turn to a different angle here and think about, I'd love to hear from each of you, how can researchers in the community continue to build the evidence base for effective strategies to prevent and manage overdose? I think we've heard from a couple of you about the changing dynamic and how do we do more in the community and research so that we can gather that information and share it. It actually, Captain Fan, I might turn to you first because it may tie to that idea of the technical assistance. But do you have thoughts here on how we might continue to build the evidence base?
Yes, data and evaluation, so very important. From the grantees on the community side, as well as on SAMHSA's side. Being able, I know for our grantees, we have a lot of questions about the program, implementation, all of that. Is the program doing what it's supposed to be doing? Our data collection is not perfect. Our tools are not perfect. And we're wrestling with that, trying to figure out the data that we collect. Is it appropriate? Is it what we need? But on the community side, definitely data collection, evaluation, publication, communication of whether the program works or not. I think that helps build the evidence. The more evidence that we have and see, we can support this is an evidence-based program and be able to push it out to the grantees. These are, what's available.
Yeah.
And the more data, the more research, the more information that we have to support, that these programs work, the better our funding will be, in terms of Congress, the decision makers, that it all helps.
Right, it's part of that cycle. I'm going to turn to Dr. Jones, but I would like Emmanuel and Mary to be thinking about what are the challenges on the community side of generating that data and what might help with that. Dr. Jones.
Let's say what's really important about building the evidence base is also to look forward. I think these epidemics tend to happen in almost a cyclical nature, so we don't want to be caught flat-footed by only focusing on one aspect of it, and then when the epidemic evolves, none of the interventions that we've developed are then non-applicable. I think that's why I like this focus on drug checking services, safe consumption, safe supply, because these are things that would be universal beneficial across substance use disorders. So if we get the opioid epidemic under control and it transitions into a psychostimulant epidemic, which there's a lot of evidence that might be what's next, we will be prepared and we'll have systems in place and we won't end up behind as we were with the opioid epidemic.
Yeah, and so even those systems then help us generate the data and evidence to deal with the new reality.
Exactly.
Okay. Great point. Emmanuel or Mary, generating data and evidence in the community setting. Emmanuel.
Well, that's a sore question for me because DanSafe actually doesn't do a great job at collecting data at the festivals where we engage hundreds of individuals in a single festival. So I'll go out on a limb and maybe say, along with data collection, I think one of the most important things we can do is, as much as possible, start treating people who use drugs with as much respect. I even think that because there is data that shows that that problematic drug use, the misuse of drugs, is often the result of low self-esteem and the self-perception that there's something wrong with you, you're a bad person because you're doing this. And I'd like to point out, even compassion towards a person using drugs can carry with it a subtle judgment. I'm so sorry that you have this problem, that you're not one of us who can not be tempted by drugs, right? Drug users need dignity and respect, and there's always a reason why someone's choosing to use a drug, whether we know, whether we believe that that's legitimate or not. In their minds, that's legitimate. And it's similar to the placebo studies, where they've shown that the method of delivery of the placebo, the more care and concern that the doctor gives to the patient, the better the placebo effect is. There's something about just feeling cared for, and that causes a better outcomes. And to reinforce this one more time, the heroin maintenance programs in Switzerland were started to remove the daily opioid users from the market and shrink the supply. And it did have that effect. So there were fewer new users. But the surprising effect is that about half the individuals who entered this program, where they can just go and get their heroin for free with no judgment, they over the course of a couple of years, half of them were able to successfully stop using. So you remove all pretense of treatment, you remove all judgment, and then they say, hey, why am I doing this? I don't really need this. Their self-esteem improves because they can get a job, they can put food in the fridge for their kids. So the quantification and collection of data are obviously really, really important. But I think the providers really changing their attitudes and being as respectful as possible to clients is going to go a long way also.
Emmanuel, I want to push that a little bit. Is there a way to link the improving the dignity and the respect that is essential here with the data collection? Is there a way to perhaps, I guess I'm struck that in order to do the research well and for individuals to want to participate, they'll need that dignity and respect on the other side. Am I thinking about that in the right way?
That's definitely one way. Yeah. They may, if they're being treated disrespectfully or judgmentally, then they're going to leave the program, not seek those services anymore. So that's true too. Also, doing more, collecting more data on the phenomenon itself, right? More studies that show that the method of delivery of services actually impacts the success of those services. That's another way to combine the two.
Yeah. Okay.
If I could add to
Please.
that, I think one of the ways to do that is to involve people who use drugs in all of your harm reduction programs and all of your harm reduction research programs. I think that's been, for us, one of the major kind of shifts that has occurred in our system as a result of overdose prevention sites, because the difference in sort of concept between our supervised consumption sites, which the overdose response was done by healthcare workers, and our overdose prevention sites, where the overdose response is largely done with people with lived and living experience, is that they've become much bigger players in the delivery of services, and as a result, they create environments that people do feel respected and seen and more comfortable. We have several overdose prevention sites on the same block as Insight, and some of the people who attend them, when we opened them, had never been to Insight, even though they live and use drugs on that block. Insight was too medical a model. It didn't feel inviting to them, even though to many of the people who have used Insight over the years, it does feel like an inviting place. And so I think it's, for me, it's really the involvement of people who use drugs in both the services and the research, and, and then, supporting the community agencies to do research, because them on their own can't do that. So, it's these academic partnerships that are kind of needed for them as well.
That admonition and reminder just aligns well, across, if we think about the FDA's portfolio and the focus on patient-focused drug development and trying to internalize that, it's logical, and yet we need to be reminded of the importance of that voice and lived experience. Mary, do you want to add anything on how we can help with the evidence-based building?
Well, I want to point out, I want to point out that Ricky Bluthenthal, who's been doing research on harm reduction programs, said to me, I think it was probably 23 years ago at this point, that we've proven that harm reduction works generally. And so the idea that we continue to need to do research, I'm not sure that we do. I think if we were to get money to the nonprofits doing the community-based work with the tools we had, as I said in my presentation, we would be able to really curb overdose deaths. I come from a nonprofit background where we work with researchers often to just fund the direct service programs. And I also just wanted to point out that Sam Rivera on OnPoint says that they're just loving on people as a way to keep people from overdosing from drugs. And so I'm not sure. I'm not sure that we need a whole other set of research.
Right. Well, I think that yes, for kind of the narrower part of the question of overdose with the supply that we know. I guess I was challenging us to think more broadly about keeping pace with, as Dr. Jones mentioned, the changing supply and that piece. So fair point on making sure that as we look to generate additional evidence, it's not for what we already know, but rather generating evidence for what it is that we don't know, which we know is we don't know the changes in the drug supply, and we're continuing to learn about individual response and uses. So good to clarify. Let's generate evidence where we have continued unanswered questions. We have a question from the chat the Q&A that we have just a bit of time to answer, and it's specifically, are there thoughts from the panel on how to implement novel things like the vending machines or other approaches where you may need to navigate different laws or different dynamics, or any thoughts there on implementing some of these more novel overdose interventions that you've all discussed here? Mary, I think you touched a bit on this in your presentation and kind of thinking through, but anything you want to highlight there?
Well, as I think I'm the only lawyer on the panel, I will say, we have these standing orders in most states that allow naloxone to be prescribed, sort of for anybody. And now we're going to have an over-the-counter product soon. So I know most states are just treating naloxone like something that can be provided, through these machines. Even in some places in Northern California, you can open up like an old style newspaper bin and take some naloxone out of it. So I'm so happy to hear that nobody's ever been prosecuted for drug checking tools under the paraphernalia laws that say that drug checking tools are illegal. So we just need to treat naloxone like it's something that can easily be given out to anybody, as is in California, and I hope most other states at this point.
And perhaps it's, again, I'm going to come back, Captain Fan, to some things that maybe in those resources among the grantees, but more broadly sharing information. I saw Emmanuel and Dr. Lasitian. Emmanuel?
Yeah, just real quick for the person who asked that question, I talked to a lot of counties, and Sacramento County is doing the vending machine model. So if they want to email me, I can hook them up and see how they're doing it. So
great. Thank you for on-the-ground responses and sharing some information. Mark, go ahead.
I think this relates a little bit to the last question you asked, because I think data is important here, and I agree with Mary's point also that we don't always need research, but sometimes you need data. And so when we first tried using the fentanyl test strips at Insight, we didn't ask for anyone's permission because we knew we wouldn't get it. And so we started using it. We felt it was, within the limits of what our exemption allowed us to do. And we designed the program in a way that we felt we could legally do it. We did it. And then we released some information about, how contaminated drugs were amongst the people using Insight. And nobody had ever seen data like that before. And And, of course, then Health Canada came looking to us to find out what we were doing, but they essentially were not able to stop it because they could see that it was valuable, information, and very quickly then they allowed all supervised consumption sites in Canada to kind of offer drug checking, and so that's been very helpful. Likewise with the overdose prevention sites, that was something that our provincial government allowed us to do, and within days of them allowing us to do that, so we had opened 5 sites in the downtown east side, and we were collecting data on how many people were coming, how many overdoses we were reversing, and as soon as you have that data, there are people who will have theoretical concerns about harm reduction or about what are these programs going to do, blah blah blah, but that you are actually saving lives from the moment that you open that site until the present, and it becomes very hard to argue against the sites. And so, in response to British Columbia opening these overdose prevention sites, then Health Canada again took a look at that data, and they basically created a federal exemption and then allowed all provinces and territories to operate what they call urgent public health needs sites or overdose prevention sites if their government chose to. So, I think the data is really important in basically showing what you're doing is working, and data can speak against these theoretical concerns that other people have, and so that's been really, I think, important for us to innovate.
Great connection of the that then as you're trying to overcome some of these barriers, the data from other experiences and perhaps boundary breaking experiences or the asking forgiveness rather than permission approach that may be used, generates an answer in that space. I think you've all had such great input. I'm going to give you each 30 seconds, if you would. I'm going to call on you I'll give you an order, but I'll give you 30 seconds to provide us what is one thing that you want to underscore from this conversation. So you have the opportunity to highlight something that either someone else has said, and it's perfectly fine to highlight something that you have said, but what do you want to help us all remember to take away from this conversation as we think about novel approaches to overdose and this just broader conversation of better understanding fatal overdose and management? And I'm going to go in Jennifer, Mary, Jermaine, Mark, Emmanuel, and hope I remember that order. Jennifer.
Mainly access. Just want to underscore, and our other panelists have touched upon, meeting people where they are. I think that's highly important. No judgments, no stigma. But yeah, I think, I can't underscore that enough.
Perfect. First set of highlights. Mary, you're next.
Well, I would reiterate that I think that we have the pharmacological tools we need to do a lot better on preventing overdose deaths, that we need to get naloxone into the hands of people who use drugs. I think that chasing other drugs that are in opioids and trying to come up with alternative naloxones it may not be possible. I think it may be an impossible task. And so double down on naloxone and listen to people who use drugs and the people who work with them for the best approaches. Thanks.
Fabulous. I think I said Jermaine, Mark, Emmanuel. If I didn't, that's the new order. Dr. Jones.
Thanks. I actually just wanted to highlight something Dr. I think Letitia brought up. It's the idea that people can't administer naloxone to themselves. Substance use disorders are incredibly isolating disorders. We found this in our research that we need new interventions such as overdose prevention sites. They help sort of fill in this gap that naloxone can't, in the sense that if people don't have someone who to use with, and so I think. I just think that was a really, really important point, and why these programs are moving forward with programs like that are nationwide in the U.S. are very important.
Yeah, that it's about more than the product being there. It's super important to have the product there. Obviously, that's a threshold component, but then there is another administering dynamic. Mark, and then Emmanuel, Dr. Lasishin.
Yeah, and I guess it's a bit related to my last point. You know, people come from all over the world to see insight. They always want to see insight when they visit Vancouver. And we do take them there, but we take them to overdose prevention sites as well, because we think insight is actually a story of the past. You know, it's a heavily regulated model that we've not been able to expand even in the context of this massive emergency. And, you know, overdose prevention sites run by community agencies and people who use drugs, you know, this is the new model. And it, you know, and the kind of way that we had to do it, you know, initially breaking federal law, but collecting data and then convincing people that this works, you know, it's just, that's the approach that most jurisdictions are going to have to take in order to kind of get to a place where maybe they could operate inside, although I don't know that we'll ever operate another site like that again because of the burdensome regulations. But yeah, so just I guess this idea to kind of work with the level of government that's willing to work with you and collect data and try to move things forward, even if you can only do it for a temporary amount of time, you'll have that data to tell the story.
Yeah. And to continue to adapt. Fabulous. Emmanuel, we're going to turn to you for the last word for this panel.
Wow,
no
that's
pressure.
Great. Well, I'll say two things. One that's been brought up. I guess they've both been brought up, but in a slightly different way. One is we've all been talking around the iron law of prohibition, right? When you ban something, the strongest version of it takes over the market, and we now have fentanyl and carfentanil and the strongest opioids. So safe supply, reiterating that to everyone. And then the other thing is, you know, which I already mentioned, you know, treating people with respect. And I'll say that in another different way as well. Some providers may think their goal is to get people to stop using drugs, right? They still carry that little judgment. And I think whether you want someone to stop using drugs or not is irrelevant. But even if you do, the best way to get someone to stop using drugs, if that's what you want, is to help them learn how to use drugs safely. So I think our job should be to help teach people how to use drugs safely. And that might seem a little contradictory and people go, oh my, are you serious, right? But that has really helped taking the stigma away and treating people with respect, because they're not going to stop until they're ready anyway. So let's keep people alive while we can, and we'll see a lot more progress that way.
Right. And that you'll never have the opportunity for them to stop using drugs if they aren't alive to do so. All right. Thank you so much, each of you, for joining us and helping us with this really illuminating conversation. Appreciate you investing your time. And we are going to go to our next presentation, where we're going to pivot from this discussion of some of the more novel approaches to then thinking through the regulatory considerations for developing opioid overdose management products, because it is a dynamic of our structure or of food and drug law that the US FDA has a particular role there. And so I will turn now, I'm going to step out of the way so that we can hear from Dr. Shrikant Nalani about those regulatory considerations. Dr. Nalani is a senior clinical pharmacologist in the Division of Neuropsychiatric Pharmacology at FDA's Center for Drug Evaluation and Research. Take it away.
Thank you, Susan. Good afternoon, everyone. I'll be speaking about the regulatory considerations for developing opioid overdose management products. First, I'll go over the approved opioid antagonist drugs, naloxone, nalmefene, and naltrexone, in terms of their mechanisms of action, indication and usage, dosage, and administration. Then I'll cover the clinical pharmacology considerations for a bioavailability study to fulfill 505(b)(2) requirements for naloxone and nalmefene, and specifically focusing on importance of reliance on label and appropriate reference products. Agency is willing and able to work with sponsors that are trying to address the public health issue of opioid overdose. We encourage sponsors to develop opioid antagonist drugs for the reversal of opioid-induced respiratory depression. The figure shows the approved opioid antagonists for various indications above the timeline, while the products withdrawn from the market are shown below the timeline. The withdrawals from market for some of these products are not due to safety and efficacy concerns. There are FDA-approved generic products for some of these antagonist products. Naloxone, nalmefene, and naltrexone are pure opioid antagonists in that they do not possess agonistic activity or morphine-like properties characteristic of other opioid mixed agonist antagonists that were developed around the same time as these drugs back in the 1960s. Over the next few slides, I'll go over the indication and usage, dosage, and administration. Naltrexone has not been evaluated for treating opioid overdose. For that reason, I'll not be discussing that further today. In the context of this workshop and in the context of opioid overdose reversal, when used in the emergency room, naloxone injectable products and naloxone nasal spray products in community setting are indicated for emergency treatment of known or suspected opioid overdose as manifested by respiratory and central nervous system depression. Similarly, nalmefene is indicated for reversal of opioid drug effects, including respiratory depression. Although Narcan injection, the originally FDA-approved product, is no longer on the market, several generic products are available. The indicated first dose for intravenous, intramuscular, or subcutaneous routes of naloxone start with 0.4 milligrams to 2 milligrams, and a repeated dose may be administered at 2 to 3 minute intervals. If after administration of 10 milligrams, no reversal of opioid effects is observed, opioid-induced toxicity should be questioned. Although Revex injection, the originally FDA-approved nalmefene product, is no longer on the market, a generic product is available. The indicated first dose for intravenous route is 0.5 milligram, and a repeated dose may be administered in 2 to 5 minute intervals. If after administration of 1.5 milligram, no reversal of opioid effects is observed, additional nalmefene is unlikely to have an effect. In terms of repeated dosing, if recurrence of respiratory depression does occur, the dose should be titrated to clinical effect using incremental doses to avoid over-reversal. Now I'll be discussing the clinical pharmacology considerations for bioavailability study to fulfill 505(b)(2) requirements. Agency recognizes the life-threatening nature of opioid overdose. Agency also recognizes the evolving nature of fentanyl-related substance use and other concomitant substances in community. We also recognize the ethical and logistical issues around conducting an efficacy trial. For that reason, 505(b)(2) regulatory pathway allows for establishing a scientific bridge between new product or a test product and FDA-approved drug or reference product by means of a relative bioavailability study. This pathway allows for reliance on the agency's safety and efficacy findings as described in an approved label of the reference drug. The relative bioavailability study can support naloxone product safety and efficacy. However, additional studies may be needed for nalmefene to support reversal of opioid overdose. Such a discussion is outside of the scope of this presentation and workshop. Specific scenarios and limitations may be discussed with the agency. For example, if a sponsor is developing a new molecule as an overdose treatment, they would have to do full development program, including preclinical and clinical safety and efficacy studies. And depending on their program, we will be providing appropriate evidence advice. First, I'll present some considerations for drug device development. A pre-assembled drug device product is mainly for caregiver or emergency medical service personnel to administer to the patient. It is not meant for self-administration by the patient. A pre-assembled device avoids potential mistakes during a very traumatic period of finding an opioid overdose patient. Although the general expectation is that a product will be developed for all age groups, that is, pediatric patients included, limitations of use may be discussed with the agency. It is important to recognize that these products are a stopgap measure while waiting for arrival of emergency medical services. That is, after administering the first dose, emergency services should be called and additional supportive or resuscitative measures may be needed until they arrive. Prior to conducting a bioavailability study, a pilot dose selection study may be conducted. It may be helpful to understand the systemic exposure at early time points and also understand the peak exposure, that is, peak plasma levels and overall extent of absorption, or AUC. The pilot study may also help in determining the need for a bracketing approach where the test product exposure can be bracketed between the lowest approved dose and the highest safe and effective dose or intravenous bolus of antagonist drug. A pilot study can also help with sample size determination. Bioavailability study is typically an open label, randomized, crossover, single dose pharmacokinetic study. Healthy male and female volunteers of 18 years of age or older who are capable of giving informed consent should be recruited. Test drug must be the to-be marketed product in terms of dose, formulation, and the device, with the focus on achieving higher exposure at early time points. The reference drug should be a US FDA approved product or original product or a generic product, and the label recommended dose and route must be used in this study. The study design should take into consideration adequate sample size, washout period between treatments, and adequate blood samples should be collected to cover the full pharmacokinetic profile of the drug with an emphasis on early time points up to 30 minutes. The bioanalytical methods should be validated to analyze the drug of interest, such as naloxone or nalmefene. The study condition needs to represent the proposed labeling recommendation. That is, subjects should be in supine position when investigating a nasal spray. Impact of site of intramuscular or subcutaneous injection on pharmacokinetics may need to be addressed if developing a parenteral product. Limitations of use and other considerations may be discussed with the agency. With regard to data analysis, in addition to descriptive statistics of standard pharmacokinetic parameters, such as peak plasma concentrations or Cmax, and overall extent of absorption or AUC, partial area under the curve, such as for 2 minutes, 3 minutes, 5 minutes, and so on, should be described. Bioequivalence type statistical approach should be applied to analyze pharmacokinetic parameters. Bioequivalence demonstration is not required when planning to exceed the labeled lowest effective dose of reference drug. Assuming reference products are parental products of the antagonist drug, that is naloxone or nalmefene, I'll be walking you through the acceptance criteria presented in this slide using a figure in the next slide. The figure shows simulated profile of an antagonist following administration of the lowest effective dose following intramuscular or subcutaneous route. The y-axis shows the concentration of the antagonist drug. X-axis shows time up to 90 minutes. Although, as previously explained, the expectation is to collect data up to 5 half-lives of the antagonist drug. Test product is acceptable if it matches or exceeds the systemic antagonist drug exposure compared to label indicated lowest effective dose. In addition to descriptive statistics of peak plasma levels or Cmax or extent of absorption, that is area under the curve, partial AUCs at early time points are also important. Partial AUCs in this graphic are shown by vertical lines, black lines at specific time points intersecting the plasma profile to the x-axis. It is acceptable when partial AUC at early time points match or exceed the reference drug, as in the hypothetical scenario 1. It is not acceptable if partial areas are lower at earlier time points, even if matching or exceeding peak plasma levels or Cmax and overall extent of absorption AUC, as in the case of hypothetical scenario 2. Partial AUCs also support repeat dosing, that is, for example, use of a drug every 2 to 3 minutes when the test drug exposure matches or exceeds the reference drug's lowest effective dose. Past approaches to developing antagonist drug products included varying nasal spray volume, varying the concentration of the antagonist drug, increasing the antagonist drug dose, using permeation enhancers, using different routes of administration. Some, if not all, of these approaches included increasing antagonist drug dose. This requires taking into account safety considerations, as talked about in the previous presentations, that may result in opioid use disorder patients in a community setting. Therefore, additional acceptance criteria will be described in the next figure with considerations laid out in this slide for your reference. This applies to naloxone and nalmefene. Following on the same theme of simulated antagonist drug profile, the figure shows the pharmacokinetic profile of the lowest and highest approved dose of the antagonist drug concentrations over time. To support systemic safety based on findings of the reference product, test product should not exceed the antagonist drug exposure compared to the label indicated highest approved dose, that is, intravenous route of reference drug. In this regard, peak plasma levels or Cmax, extent of absorption or AUC, and the entire profile should be compared. Based on these criteria, PK profile of hypothetical scenario 1 appears to be well within the clinical experience known from the approved labels. The hypothetical scenario 3 presents a case where the initial exposure to antagonist is higher than the lowest effective dose or the intramuscular or subcutaneous route, and well below the intravenous antagonist pharmacokinetic profile within the first 30 minutes. However, comparison over the entire pharmacokinetic profile is also necessary. On the other hand, the systemic exposure with hypothetical scenario 4 exceeds the systemic exposure with the intravenous route of the reference product, both in terms of peak plasma levels and the overall extent of absorption, or AUC. In such a case, additional information or justification will be needed to support its systemic safety. Sponsors may use the highest dose of antagonist drug as it is described in the product labels, or they may utilize literature information from clinical trials and clinical studies as appropriate. It is expected that an antagonist drug is repeatedly used, particularly in community setting, until emergency medical services arrive. Considerations similar to those laid out on slide 19 apply here. Well, the slide numbers are different, but 2 slides ago, whatever the considerations were laid out apply here. I will present these considerations using the figure in the next slide, while you may refer to the slide before. The requirement for repeated dose of antagonist drug depends upon the amount, type, and the route of administration of the opioid being antagonized. Simulations in the figure show pharmacokinetic profile of the reference antagonist drug administered every 2 to 5 minutes for 5 doses at the lowest effective dose, and similar to when single dose pharmacokinetics are evaluated, even with repeat dose, the test product should not exceed the label indicated highest effective dose. In this regard, sponsors may conduct PK simulations to understand systemic exposure with multiple dose administration. The test product should be compared in terms of Cmax, AUC, and the entire pharmacokinetic profile. The PK simulations of hypothetical scenario 1 appears to be well within the clinical experience known from approved labels. However, the simulation for hypothetical scenario 5 exceeds the systemic exposure with IV route of antagonist product, both in terms of Cmax and AUC. Products such as hypothetical scenario 5 pose safety issues in opioid use disorder patients. Additional information as previously mentioned, such as from the label or published literature from clinical trials and clinical studies, may be used to justify the exposure. With that, I will present few guidances that are available to facilitate the conduct of a successful bioavailability study. These are very well-established guidances in the area of clinical pharmacology. Also, some of the references cited are provided here. These are based on NIDA-funded research, PubMed, and information in publicly available labels. I would like to thank all the colleagues in Center for Drug Evaluation and Research that are committed to working with sponsors for the development of opioid overdose reversal products, and also Reagan-Udall Foundation for facilitating this workshop. Thank you all for your time and attention.
Dr. Nalani, thank you so much. That's a virtual treasure trove of information as folks look to develop new products and what it is that the agency is looking for, which is obviously essential in thinking through what is it that the agency expects and how to meet that standard. So thank you so much for joining us. We're going to roll to our next 2 presentations, and then we'll see you again on the panel that follows. But let me turn now. We want to pivot from the regulatory considerations baseline to talk about other considerations for product development in the overdose management space. And so our first presenter for this section is Dr. Karin King-Malley. who is clinical instructor of emergency medicine and medical toxicology at the University of Pittsburgh Medical Center. Dr. Malley at King Malley, I see you. Go ahead and take control of the slides, and we are anxious for your presentation.
Awesome. Well, I will endeavor to make Zoom function smoothly. I'm one of the few people, I think, who did not get extra Zoom time during the pandemic because I was in person clinically. So there we go. All right. So I'm going to talk about a clinical perspective for some considerations of overdose management. So disclosures, I do not have any financial disclosures. These cases are not based on like specific patients. They're based on kind of the depth of clinical experience, and just kind of so you understand the perspective I'm coming from. I practice emergency medicine and medical toxicology in Pittsburgh. Our specific illicit opioid supply currently is it's really fentanyl and fentanylagogues. We do not see 6-monoacetylmorphine or like heroin really much anymore. I think I've had a drug screen positive like maybe 5 or 6 times in the last 6 years for 6-monoacetylmorphine. So it's mostly fentanyl. We do see a bunch of pressed pills, and we see accidental opioid overdoses from people who are intending to use benzodiazepines, amphetamines, or cocaine when there is fentanyl mixed in. We see some xylazine. We do not see a large amount. So that's just kind of my background in terms of the drug supply that I see. And I work primarily clinically, both as a medical toxicologist and emergency physician. We have a pretty robust consult service at multiple hospitals, and we also do addiction medicine in the inpatient setting for some of those hospitals. And so I take care of someone with an opioid overdose essentially every shift. So we're going to talk about this in kind of a case-based perspective, because I always feel like that just kind of illustrates things better, at least from my perspective. So we're going to talk about kind of a more like the ideal, like what would the ideal management look like? And then we're going to talk about the extremes, the severe precipitated opioid withdrawal, and then also late or ineffective reversal. Now, this is not to say that we see equal percentages. It's not like we see 33%, 33%, 33%, right? We see, certainly this is just giving you kind of the spectrum. And certainly it's more of a minority of patients who have really severe precipitated withdrawal or who come in with a potentially fatal overdose. But just want to give you that kind of perspective. All right, so we're going to start with the same base case and then kind of look at how it could change. And so we have a 29-year-old male. EMS is called because of a suspected overdose. Family basically says they saw him last about a half an hour ago. He went down to the basement. And then when they didn't see him again, they were like, oh, this is weird. Go check on him. And they find him unresponsive, not breathing, and that there are stamp bags on the ground next to him. And they're administering intranasal naloxone while they're on the phone with EMS. So we'll talk about in case 1, kind of what an ideal overdose management would look like. Case 2, that severe precipitated withdrawal. In case 3, that late or ineffective reversal. So for case 1, all right, so the family administers naloxone. Paramedics arrive. Patient is breathing spontaneously, but his respiratory rate is a little bit on the slow side, 8 breaths per minute. So that's what we call bradypnea in clinical setting, and a pulse ox saturation of 80%. They're able to establish an IV, and they're able to give an additional 0.2 milligrams of intravenous naloxone and assist with ventilation via bag valve mask, basically to help bring up the patient's oxygen and eliminate carbon dioxide while they're waiting for the naloxone to really kick in and work. Over the next couple of minutes, and really, say 5 minutes. I really should have made that more like 30 seconds because intravenous naloxone's a lot faster than that. But over the next like 30 seconds to a minute, patient's native respiratory rate rises to about 16 breaths per minute. Pulse oxygen saturation rises to 98%. And the patient's a little bit drowsy still, but is, responding to verbal stimuli, meaning when you talk to him, he's sort of talking back. And they're able to transport the patient to the emergency department for further monitoring and treatment. So why did this work? Why is this kind of the ideal? So there's a bunch of different things that go into getting someone care after an overdose. One of the biggest things is recognition. Someone has to recognize that there's a problem. And so bystanders were able to recognize that there's a possible opioid overdose. They had naloxone. This is a very common issue that we work very hard to fix. Our hospital has free take-home naloxone, which we give out to literally everyone who will take it. But still, having it with them and not, in their car or in their house, it's hard. And they knew how to administer it. People don't want to hurt other people. It's the bottom line. And so, especially when it comes to medical things, people may be worried that they're going to hurt someone by, jamming this up their nose, or using this nasal spray. And so people may be a little bit hesitant to administer the naloxone if they're not 100% sure, for instance, or if they're just not exactly sure how it works. So they knew how to administer it. They were able to connect with EMS services, and EMS was called. Another thing is that EMS was able to obtain an IV. I love being able to, when I need to reverse an opioid overdose, having an IV is really helpful because it means I can really finesse the reversal. Because ideally, I want someone to be breathing, but not to induce that fight or flight response that occurs when all of a sudden you reverse everything. Because there's just a lot of health considerations that occur when someone gets reversed that quickly, which we'll talk about next. But having an IV means that you can give small doses and see the effect immediately, and know exactly kind of where you're getting with that reversal. All right, so let's talk about the kind of less ideal scenarios. So we'll talk about the severe precipitated withdrawal. So same setup, family administers naloxone. In this case, the paramedics arrive, they can't get an IV, and he's really not breathing well at all. So they give him 2 milligrams of intramuscular naloxone. And then, pretty rapidly over the next couple of minutes, he has return of consciousness, but maybe not like awareness and moving everything around, but maybe not truly interacting with you. Begins to vomit and then gets progressive psychomotor agitation. Now, psychomotor agitation is a term that we use in medicine to kind of describe a clinical picture. And really what we're trying to describe there is this sense of fight or flight response. And frequently patients, they may not be consciously trying to fight you, but their whole body everything is telling them that they are about to die, something horrible is happening, and they're literally fighting for their life. And that can mean that they are fighting people who are trying to save them because they don't realize it, because their body's kind of waking up enough, but their brain is not yet quite turned back on again. And this can be really dangerous to the patient. It can be really dangerous to family that's nearby. It can be really dangerous to EMS, and can be very difficult to manage. So the agitation worsens to the point that the patient is a risk to himself and medical personnel. So they try verbal de-escalation, but that's unsuccessful. And so they try 5 milligrams of intramuscular midazolam, and then apply physical restraints in order to transport the patient to the hospital. So on arrival to the emergency department, the patient is still severely agitated. 6 security guards are required to assist in moving the patient from the stretcher, and that's not an exaggeration. I have had this scenario almost exactly, actually, like less than a week ago, I had almost this exact case on an overnight. That in that case, we were able to give him a little more midazolam and not have to intubate, but and that's the majority of cases that we're able to avoid intubation. However, not all. And so they get the patient over onto the stretcher, and the ED assessment is a 29-year-old male with a heart rate of 140. That's very abnormal. Normal heart rates are 60 to 100 for adults. He's diaphoretic. That means like pouring sweat, like the type of pouring sweat that like the EKG leads don't stick. And you got to keep changing them out because they're literally sweating off the patient. He's actively vomiting. He's agitated, and he's hypoxic, meaning oxygen saturation is low. And anyone in emergency medicine will tell you that's a dangerous combination. Someone who's vomiting and confused is a really dangerous situation because the risk of them inhaling their own vomit is then really high, and that can be, not just can, it is fatal in many cases, and can be very dangerous. And so in that case, they decided to intubate the patient for airway protection. And just because I know we have a wide audience, intubation is when we put it in a breathing tube and put someone on a ventilator. So obviously this is not ideal. It's certainly high risk for the patient. And in terms of having long-term sequelae like pneumonia and other injuries, and not ideal for the medical system either, obviously. And so let's talk about some areas that could be improved in this situation. And I know some of these are kind of in some version of ongoing research, but there are things that are interesting. One of them is the use of partial opioid agonists for reversal. There's been, some startings of some publications of use of buprenorphine for reversal of opioid overdoses, which is super interesting. And I've done a couple of times, but in very unique settings, not actually an illicit setting, but a patient with renal failure who was unable to metabolite their morphine 6-glucuronide. But anyways, if you want to hear more about that or want to talk more about this idea, feel free to email me afterwards. But so use of partial opioid agonists is one thing that could certainly help here, and is being looked into in terms of, is this going to reverse the respiratory depression without precipitating really severe withdrawal? And does this work? And is it something that we should think about? Another thing is, I would love for there to be an easier way to titrate reversal agents, opioid antagonists, without a patient with IV access. Frequently in someone with substance use, especially if they have a history of intravenous use, it can be really difficult to obtain intravenous access. And then you're going to be more reaching for intramuscular or intranasal routes. And those, they take a little longer to work. And so what we tend to see happening is then people repeatedly give doses while they're waiting really for the first dose to really kick in. And then it's kind of gone way past the reversal you want, based on the fact that it just takes a really long time for those beginning doses to kick in, and you're dealing with a life-threatening situation. So people are just trying to get, the patient better as fast as possible. So allowing us to administer without necessarily, is something that's very titratable without necessarily needing an IV, would be very helpful. And then an agent that would selectively reverse respiratory depression without reversing everything else and tipping someone into that fight or flight response would certainly be very helpful. All right, so let's talk about cases of late or ineffective reversal. So same case setup. And the family reports to the patient at 911 that the patient has a pulse but is not breathing initially. Paramedics arrive to find the patient pulseless, and they start ACLS. So that's advanced cardiac life support. That includes CPR. It's like CPR plus all the medications and a breathing tube and everything else that we do in both the hospital and the pre-hospital setting. And the initial rhythm is asystole, which is like no organized electrical activity, basically. And then after 10 minutes, they get return of spontaneous circulation, and they transport the patient to the emergency department. However, in this case, they get a CT right away, which shows loss of gray-white differentiation on the CT. That's really just a fancy way of saying that if you have those brain changes on CT right away after a cardiac arrest, it's basically incompatible with life, unfortunately. So, how could we prevent this? What can we do about this? And so there's a lot of different ways, and I know that this whole conference is about helping to prevent this. But some ideas, a pre-use agent, again, this is maybe controversial, but is there something that can prevent the respiratory depression that someone could use before using a substance to hopefully prevent them from having respiratory depression? An overdose automated overdose alert system, like a life alert pulse oximeter, or something like that. Devices to allow lay people to administer ventilation more easily. And then you have to think about the idea of supervised injection sites as well. It's an uncomfortable idea, and it's an uncomfortable thought for a lot of people. But I've had to look at a 30-year-old widow with a new baby after I just pronounced their 29-year-old husband in their basement after an opioid overdose. And so when you've had to do that, I can't even tell you how many times you're willing to look for, uncomfortable solutions. And so these are just some ideas, and hoping that we can build on stuff. So thank you all very much. This is my email. Feel free to email me if you have any questions.
Dr. Malley, I feel like we were almost with you in your daily experience. And so thank you for sharing your expertise in such a powerful way to help us think through the clinical components. I have one quick clarifying question, and then we'll turn to our other presenter, and then we'll bring you back for the panel. But clarifying question, when you get information about the opioid that was involved in the overdose, so right, and then in retrospect, can you distinguish when someone has taken fentanyl or a fentanyl derivative versus oxycodone or something similar? Could you determine that by the extent of precipitated withdrawal following naloxone administration? Sorry, there are like three tangents there.
Yeah, not necessarily. I think the big thing that we see is that people stop breathing a lot faster with fentanyl because it's so potent. And so your time window for intervention is so short that you're either more likely to have an ineffective reversal or to have a severe precipitated withdrawal, because that fight or flight response is all about, at least we think, the amount of downtime, the amount of time that they're not breathing. And then all of it, and the extreme, like how extreme was the reversal? So were they like a little bit of an overdose and then they get reversed a little too much, or were they like really, really deep and then they got really reversed? And so, yeah, I hope that kind of answers the question.
Yeah.
And we don't have, it's not like we're getting real time data on what someone's exposed to. So this is usually, this is our LCMS testing that we would get 24 to 48 hours later. So
yeah,
not clinically helpful, but very interesting later.
Right. All right. Really helpful. Thank you again. And we will see you when we come back for the panel. But I'm going to turn next. We have one more presentation before we come to our panel discussion. And that is where we will welcome Dr. Ivan Montoya to the stage. Dr. Montoya is the acting director of the Division of Therapeutics and Medical Consequences at the National Institute on Drug Abuse. Dr. Montoya, I'll ask you to turn. There you are. I see you, and I know you're ready to go.
Yes. Thank you, Susan. Thank you so much for the invitation. And I'm really excited to communicate to you some of the product development that we are supporting at NIDA. I have to make a couple of disclosures. First, I don't have any financial disclosures. And second, most of the information, or all the information that I'm presenting, is public information. As you probably know, all what I'm presenting is research. All the products are not FDA approved, and there's a lot of confidential information, but that confidential information is not going to be presented here. Also, I want to say that the presentation that I'm making is not an exhaustive review of all the products that are being developed. Most of the products that I'm presenting are being supported or funded by NIDA or by NIH in general. Let me see if I can advance my slides.
Click on it and then hit the down arrow. See if that works. Oh, and you hit mute too. Oh, we've got you. We're still muted. Let me see if we can unmute you. We still can't hear you, Dr. Montoya. There. Now
Okay,
you're
can you
unmuted.
hear me now?
Yes. Perfect.
Okay. So Dr. Mali's presentation was really fantastic because it is a great segue for what are the describe what the clinical needs are in terms of product development for opioid overdose. So what we heard from Dr. Male is that, one, we need safe and effective medications for opioid overdose reversal, medications that can work fast, that can work for sufficient time to prevent all the complications of the overdose, particularly respiratory depression, and that can work without producing severe precipitated withdrawal, like the case that she presented. So that's the other important need, is that there is not a medication that does not precipitate withdrawal, but also a medication that can prevent the re-narcotization, prevent that people fall into an opioid overdose again. In addition to that, and we heard from Dr. Male, is the respiratory depression. So this is what kills the patients with opioid overdose, is the respiratory depression. Of course, there are other cardiovascular complications, but mostly is the hypoxia or the lack of oxygen. We know that one of the clinical challenges, and we have heard during this conference, is the fentanyl and its analogs, especially carfentanil. And we know that they have specific pharmacological characteristics that make them particularly difficult to treat, including that the fentanyl has very high affinity for the receptor and also has high lipophilicity. So then it stays in the receptor for a long time. There's also a concept that, although Dr. Mali did not mention it itself, but in the last scenario that she presented, is the concept of naloxone-resistant opioid overdoses. That is, some patients, and we don't know, there are some idiosyncratic characteristics or specific individual characteristics that, although they overdose, and their overdose cannot be reversed with naloxone. Fortunately, those are few cases, but they exist. And the last clinical challenge is the wooden chest syndrome. We have not discussed this very much during this conference, but anesthesiologists are very aware and concerned about this syndrome because it's a syndrome where people, especially with fentanyl, people, the thorax becomes so rigid that people cannot breathe. So it's usually very difficult or almost impossible to revert with naloxone. So those are the challenges. So what are we doing for those challenges? So what are some of the research approaches? So first, we have medications. Of course, this is the purpose of the FDA, and partly regulate medications, and that is very important. And our division at NIDA works very closely with the FDA in advancing the development of medications to treat opioid overdose and respiratory depression. So we have small molecules. We have, and we heard of the mu opioid receptor partial agonists. I'm not going to spend a lot of time on that because most of that research is not with new products, it's mostly with buprenorphine. But we have the mu opioid receptor antagonists, and I'm going to talk about a couple of products in this area. Then we have a very interesting approach, is what is called drug sequestrants. Then I will talk a little bit about some of the research that NIDA is supporting with respiratory stimulants. Then I'll talk about biologics, which may be surprise for some of you, but NIDA is supporting the development of what is specifically monoclonal antibodies, but also vaccines. But in this case, I will be talking more about monoclonal antibodies for treatment of overdose. I will also describe some of the devices that are being supported by NIDA, and we also have some research looking at digital therapeutics. So let me start with the mu opioid receptor antagonist, and we already heard about namelphin. So there is a formulation of namelphin, it's an intranasal formulation that is being developed by a company, Opiant Pharmaceuticals, and the name of the compound is OPNT 003. So nalmefene is an inverse agonist of the mu-opioid receptor, and is also a weak partial agonist of the kappa opioid receptor. And in this case, this compound is a combination of nalmefene plus an absorption enhancer. It's called dosedyl maltoside, or it's also called MMD. And that the acronym is MMD. What it does is to increase the absorption of nalmefene, and this is an intranasal formulation. So in those figures, you can see that the intranasal absorption of normal nalmefene is very poor, is very bad, is not enough to revert an opioid overdose. But when this absorption enhancer is added to the molecule, to the intranasal formulation, the absorption is very fast, and it's also the peak, as you can see here, the peak is quite high, and it lasts for a long time. So this is an extraction of the figure here, and here we can see from 2.5 minutes to 20 minutes, to 2 hours, sorry, the curve of the PK of this intranasal formulation of naloxone. This is data that was published in study done by our group at NIDA, and the first author was Phil Kreider. And right now, this compound is, as I said, being developed by Opiant, and NDA has a rolling submission, and the FDA is already reviewing this data. And so this is a compound that is quite close to being reviewed by the FDA, and who knows, hopefully will be approved, and then clinicians will have an additional medication to treat opioid overdose in their armamentarium. Another compound that is being developed, and this is the data that is public. I don't have a lot of information that is public information for this compound. Is a pocket. It's from this company called Pocket Naloxone Corporation, and they have developed a novel intranasal swab. It's a swab like you introduce in your nose and deliver a method for naloxone intended to be affordable and used in over-the-counter settings, and hopefully for a $10 dose. The first human pilot study has been completed, and they are followed with a final pivotal bioequivalence study, like the one that was being described before. And the company is planning to submit an NDA to the FDA and hopefully apply for priority review. So this is another, it's a little bit behind the intranasal nalmefene, but it's another one that is in the pipeline and with great expectations. Now, the other approach that is being supported is this a compound called CS1131, and the company is Clear Scientific. This is a very unique and interesting approach. This compound is an acyclic cucurbituryls, and is a compound that has kind of like a C shape. And what it does is scrubber molecules and sequester the opioids in vivo and make some big complexes that are cleared by the kidney. So what it does is basically sequester the fentanyl, or the drug of abuse, and prevents the access of the drug to the brain, and sends it to the kidney to be metabolized and excreted. This, I just want to say that one of the big challenges that have been presented during this conference is the issue of polysubstance abuse. Well, this compound, if successful, again, this is all research, if successful, it will have also the option of being a sequestrant for other drugs of abuse. Especially right now, NIDA is supporting the research looking at this compound for methamphetamine intoxication. So eventually, this compound could be sequestering like fentanyl plus methamphetamine, for example. So this is one that is in early stages and is not ready yet for an NDA, but it's a very interesting approach, very interesting compound, and it's something that can be very promising, especially for polysubstance abuse. The next approach is the monoclonal antibodies. So the monoclonal antibodies, those are antibodies like similar to the antibodies that are produced for treatment of infectious diseases, in this case, or instead of a virus or of a bacteria or whatever, the monoclonal antibodies are fighting, in this case, is the drug of abuse. And so there is, the monoclonals are, what they do is they fight the drug of abuse. They attack the drug of abuse and create a very large molecule that prevents the access of the drug of abuse to the brain. And and any drug that has access to the brain, also it is extracted from the brain. So what it does is basically preventing the neurotoxicity, and in the case of fentanyl or the opioids, is the effects on the respiratory center in the brain to prevent the respiratory depression associated with opioid overdose. The beauty also of the monoclonal antibodies is that they can last longer than naloxone, but also they can be administered with naloxone. So one potential approach is, because the antibodies may take a little bit longer than naloxone to produce the effect. Well, one possibility is to co-administer the naloxone to make sure that that naloxone fights the opioid really fast, and then having the monoclonal preventing the access of more opioids into the brain. And in this approach, NIDA is supporting research to several groups. One group is at the University of Minnesota, and this is, as I said, public data of this monoclonal antibody, where you can see in this figure that the brain fentanyl levels have been significantly diminished by this monoclonal antibody. And we can see also the oxygen saturation. So we can see that the monoclonal antibody has prevented the hypoxia or the lack of oxygen associated with the fentanyl intoxication. So this is a project that is still in animals, but we are hoping that this will go into humans pretty soon. There's also a NIDA supporting this company called Cessation Therapeutics, and Cessation is developing monoclonal antibodies for fentanyl overdose, and they have those 3 products, and some of those products are in late stages of preclinical development. And there is also another product that is looking at a monoclonal antibody to fight carfentanil. So this is preventing the overdose with fentanyl that, as we heard during the conference, is very, very difficult to revert. Now, a big challenge that we have is opioid-induced respiratory depression. And unfortunately, I don't have time to go into details about each one of these compounds, but we heard yesterday during one of the presentations, the ENA-001, which is produces a functional inhibition of the big potassium channels in the carotid bodies and prevents the hypoxia. There's also an inhibition of the TASC1 and TASC3 tandem port potassium channels. AMPA-kines, those are AMPA receptor allosteric modulators that enhance glutamatergic synaptic transmission and stimulate breathing. We also have the kappa receptor agonist. There's a compound that was also mentioned yesterday, dexmedetomidine, is a central alpha-2 agonist that may increase ventilation. Intranasal leptin, this is a hormone that apparently upregulates breathing. And there's another compound, this is C. All those studies are in preclinical research, but I just wanted to include them in my presentation, so to see that there's work being done in advancing medications to treat opioid respiratory depression. Now, switching gears, and I know my time is almost over, but I want to mention briefly, we are also working on supporting research with devices. This is an implantable closed-loop system for delivery of naloxone. We already heard about the need for this type of approach. This is an implant that senses when someone has overdosed, and it delivers naloxone to prevent the intoxication. There's another approach that is looking at the phrenic nerve stimulation for people with respiratory depression. The phrenic nerve is in this area is stimulated. It stimulates the diaphragm, and then it helps to prevent the respiratory depression. And the last one is this project that was recently funded. Is also an automatic portable system for detecting and treating opioid-induced respiratory depression. It's portable, it's wearable, and it functions using acoustic patches to deliver naloxone and to treat overdose. So as you can see, there is a lot of hope. There's a lot of research. Again, it's not, I didn't present all the research. Unfortunately, there's no time, but I just want to say that there's a lot and there's a lot of hope in terms of getting safer and better treatments for opioid overdose. Thank you so much for your attention.
Fabulous. Dr. Montoya, is really important to hear that from you about the things that are in the pipeline and might, in fact, take us to having alternate approaches for managing overdose. So I want us to go actually back one slide and then pull our full panel up for discussion. Actually, we can pull the slides down because we are going to turn to our broader panel here to react to what we heard from Dr. Montoya and from Karin. So let's pull up on the screen Dr. Jesse Pines, who is the National Director of Clinical Innovation at U.S. Acute Care Solutions. Welcome, Dr. Pines. Philip Feudy, who is the Harm Reduction Program Director at the Mountain Center. Philip, I think I saw you. We'll see you come up. There we go. Phil is on camera now. Then also Dr. Nab Gazbuta, who is Senior Scientist and Injury Prevention Research Center Innovation Fellow at the UNC Gillings School of Public Health. Great to have you back with us. And Jessica Paulson, who is the Associate Director for Digital Health in the Office of Product Evaluation and Quality at FDA's Center for Devices and Radiological Health. And Dr. Nalani is coming back along with Dr. Malley from all of their presentations. So I'm going to do a quick question for each of our new faces, and then we're going to mix it up and have a dialogue here with everybody who's on screen. So let me first turn to Dr. Pines. So thinking through what's been presented so far, how does that land with the work and the research that you're doing?
Sure. So a couple takeaways. It was really amazing to see all the products that are coming. I'm the head of innovation for a large physician group, and a lot of what we do is try to really push out programs across all of our sites. We have 280 emergency departments across the U.S. that we staff, and some of our programs are related to opioids. We have programs where we're trying to reduce opioid prescribing among emergency physicians, which we've been very successful in doing to try to not get people hooked in the first place. And then also we've been trying to, and very successful in developing what are called medication for addiction treatment programs in our sites for the delivery of medications like buprenorphine and naloxone after people have overdosed. I think it's amazing to see all the other potential tools that are coming in the pipeline, and other things that we'd be able to deliver to patients when they come in and they have an overdose, and we get them to wake up, and then we can have that conversation about what's next. Also on the innovation side, it's interesting to see where naloxone doesn't work, and there are cases where you give the naloxone, it's clearly an overdose, and opioid overdose. It may be carfentanil, it may be some other very high potency opioid, and having other ways to treat those patients, I think will be very, very effective.
So I'm hearing optimism and immediate application when available. Is that fair? Quick application.
Trying to push out clinical innovations is never quick, but
right.
Eventually.
Enthusiasm for it. An aspiration too. All right, great. Thank you. Phil, I want to turn to you too. So similarly, reflecting on what has been presented, what do you hear as opportunities and challenges from the presentation?
Yes, and thank you to the panel for having me here, the organizers. I mean, in a way, I'm all about marching into the future. I think, you know, a lot of these things are really exciting, and I think, personally, in my work and in the larger harm reduction world, I believe that we need as many options out there as there are people who potentially need an intervention. I think what concerns me is, you know, as the gap in social and economic disparities and access to services and all of that continues to increase and go unaddressed, the individuals who are most at risk are, you know, have less and less of an ability to manage or even consent to some of the more advanced interventions and stuff that are being proposed. Like, I mean, a naloxone pump sounds great. Who is going to be in a position to consent to that as an intervention appropriate to them, right? That kind of stuff, you know, really concerns me. I think, like Alice presented yesterday, we also in Rio Arriba County, New Mexico, where I primarily work. For those who haven't been around for a long time, Rio Arriba County was the #1 place where you were likely to die of a drug overdose from the time people started paying attention all the way to 2017. Since fentanyl has come on the scene, we've seen a stabilization and a decrease, just as Alice reported also, in the number of doses people are reporting using per intervention. And we've now seen a sustained decrease in the number of overdoses being reported to us, which is another topic. The conclusion I come to with that is that the people that are most at risk in the community are no longer the people that are engaged in harm reduction services. And that's another tangent. But I think that what we're hearing anecdotally from people when they're reporting overdoses and the reversals to us is something that came up when in Karen's #1 scenario, that it's directly related to the timeliness of the intervention. And through 2018, 2017, 2018, 2019, we were very much engaged in a saturation of our community with naloxone. And we were beginning to see the impact of that with, you know, EMS services reporting, you know, that by the time they got on a scene, people had already been administered naloxone and were up and moving around already, and that the only people that were dying were people that were alone when they overdosed. And we got very excited in 2019. We actually saw the biggest decrease that we had seen in Rio Arriba County in a decade of fatal overdoses, and unfortunately we got double whammied by fentanyl showing up at the end of 2019, followed by the pandemic. So I'm kind of back to basics on things that people have already said. I think I do recognize that EMS and medical folks and law enforcement and everybody, they all have different priorities, maybe in the same given situation. Right. But I also, I think we can still just take it right back to the baseline. We do have fantastic tools and we haven't figured out how to get them in all the places that they need to be.
Mm-hmm. So continuing to do that as we think about new products, but also making sure we're deploying what we already have in a way that they can be used. Yes. I want to continue on the harm reduction piece and turn to you, Dr. Dasgupta. What would you add to our discussion there?
I think I was really encouraged to hear Dr. Montoya talk about price. And I think, these medicines sound great. I don't want these to be medicines just for rich people. I think what we really need to, and I know price isn't like a core mission that FDA can make decisions on, but it's something as part of the broader public health infrastructure. We need to pay attention to how these antagonists get into the hands of people who can do the most reversals. I'm standing at the Remedy Alliance warehouse. There's 80,000 doses of naloxone behind me, and we distribute about 10 to 15% of all naloxone used in the United States, and that's directly to community-based harm reduction programs. Now, with the so I think like there needs to continue to be innovation, not just at the molecular level, but at a systems level, on how we make it easy and affordable for the people who can do the most good to have access to these tools.
As often happens in these conversations, Nab, you give me something that I'm going to repeat elsewhere, and that's going to be that we need more than innovation at the molecular level, right? That we need the innovation at the other pieces. So just, I'll give you credit, but I'm internalizing it now. Dr. Paulson, I want to come to you for a note on the world of devices and remind us share with us, what should researchers and sponsors be thinking about related to device product development?
Sure. Yeah. Thank you so much for the question and for the really great presentations. So from the CDRH perspective, maybe I'll briefly highlight just a few considerations. So first and foremost, I just want to underline that CDRH is committed to supporting development of innovative devices that are both safe and effective to help mitigate the impacts of the opioid crisis. We've been taking steps to support these efforts by fostering the development of devices in this space, recognizing just the sheer breadth and complexity of the crisis in front of us. And that's going to require a broad, multifaceted approach, at the system level, beyond the molecular level. Medical devices are a really important piece of that puzzle. So we're seeing a lot of devices under development that are aiming to meet the needs of the community. So we're very interested at CDRH in working with innovators to bring new devices to market that can help address the crisis through an efficient regulatory process. So for anyone that's not aware, I thought I'd put in a quick plug for a couple of the programs that might help and could be leveraged here. So our first program that I wanted to highlight is just our pre-submission program. It's just a really good one to take advantage of. This is a mechanism for developers or sponsors to get specific feedback from FDA on questions that they have as they're developing and planning for validation of their device. So incorporating that early feedback into their plans can really help facilitate the process. And then the other program I did want to highlight is our Breakthrough Devices program. So this aims to provide timely access to certain devices by speeding up the development, assessment, and review while preserving our statutory standards. So it's a voluntary program, but devices that are related to opioid use or opioid use disorder may be really good candidates. So I would definitely recommend keeping that in mind. And then finally, I just want to highlight the opportunities in this space related to digital health. So digital health technologies can provide a more holistic view of an individual's health. And some of these digital health technologies could provide potentially useful diagnostic or monitoring capabilities. And it could be anything from a mobile app on your phone to a machine learning algorithm for risk prediction. Maybe it's a wearable or a fitness tracker with capability to detect signs of respiratory depression or possible overdose. There's just so much opportunity in this field, certainly challenges too, but I think digital health solutions could play a really important role here.
Well, and thank you for that, because then it reminds me of a question that I want to ask Dr. Montoya, and then I'm going to come back to Jessica and Shrikant to follow up on it. But Ivan, you mentioned the drug-device combination that can, it's being explored to detect and treat an overdose. Can you comment, is there any work to show accurate overdose sensing? So how do we think about that? And are you aware of any research that would help in the development of products that are trying to explore accurate overdose sensing? Oh, you're on mute.
Okay, thank you. I now can unmute. Yes, absolutely. And one of the devices that I presented is trying to accomplish that function, is to detect an overdose, and is also using a machine learning algorithm to try to identify the signs of an overdose and combine the information to determine if it's necessary to deliver a dose of naloxone. It's still early, it's very preliminary, it's still in animals, but that's the idea, is to be able to detect the overdose and treat it. And also, there's another additional function of calling 911. So it's like connecting to your cell phone and calling 911 in case of an overdose. And I just want to make a comment about, we work very closely with CDRH, with the Division of Devices, and it's great to hear the comments from CDRH, because I think our NIDA has been really enriched by this wonderful interaction with CDRH. And hopefully devices will be developed.
Yeah, fabulous. So let me do just a quick follow-up to Drs. Nalani and Paulson. Do you want to add anything from the FDA's perspective about products that may be able to sense overdose?
From the CDRH side, I probably can't comment on specific, accuracy requirements or what we're looking for, but it's such a good question, and it's a perfect example of something that I would hope that the developer would come to FDA early on. Like I just mentioned, that pre-sub program, that's a perfect illustration of where we can add value and engage early to really get that alignment on what kind of expectations are we going to need, so that there's no surprises in the review process, and we can really try to bring these to market as soon as possible.
Thanks, Susan. So it's a actually very good question. This question is, but how do you know what a given patient has overdosed on? And that question is something that we have always grappled with, going back now today it's 2023, but going back 15 years, we have always asked that question ourselves. In that regard, what we know now, and you have seen the presentations yesterday, the pharmacology presentations yesterday, with regard to naloxone and nalmefene. For a sponsor, the focus of their program determines their success. What do I mean by that? The primary indication that they are pursuing, that is, it has to be known or suspected overdose as seen by the respiratory depression or CNS depression. And what patient population are they targeting? They need to be very clear on that. The treatment duration, are they targeting in the community setting? Are they targeting in the emergency room? They need to be very clear on that. Their focus will determine their success. And dosage forms. There needs to be a portfolio of dosage forms. Right now, agency has experience. We have worked with sponsors that have tried developing auto injectors, injectables, nasal products. Tomorrow there may be something else, but the sponsors have to be very clear on how it is that they are going to help the caregivers, or help these caregivers then reverse overdose in the patients.
Which is a great lead in to a question I want to open up to each of the panelists. And so whoever's first to either raise their virtual hand, raise your real hand, or unmute, you get to be the first one to fire away at an answer. But thinking about that characteristics piece, what are the characteristics of an ideal overdose management product do you think are needed? And I'll say Phil and Nab, I already heard you about price, right? So so thinking about other components, what other characteristics of an ideal overdose management product do you think are needed? Karin, you gave us some. Well, Nab, you unmuted first. You win. Go ahead.
Okay, sorry. You can go to Karin.
That's all right. Nope. Go.
So I think overdose is kind of this very general word, right? There's specific components of an overdose. There's different types of overdose. I mean, one of the tools that could be really helpful are tools that can help people feel less high, right? Is there like a way to intervene before it gets even to an overdose when people feel like, I mean, especially with stimulants, right? You know when you're over amping and it comes on quickly or slowly enough that you can, could you self-administer something that makes you less high? And I think that's one of the, it's like we are obsessed with overdose and overdose deaths because this is like a hard measurable endpoint. On the ground, the thing that a lot of folks are asking for is something that will kind of help them step back from a mistake of taking too much when they know that they just did.
Right. So that it's something that would help you know you're approaching a precipice.
Yes, knowing and also reversing it with autonomy, right? A lot of these tools we're talking about are so embedded in medical delivery care systems that we really need to think about the ethics of some of how we actually use these medications. I could see some of these being used for coercive purposes without patient consent in a meaningful way. Criminal justice system already does this with a lot of injectable products, like implantable products. And so I think, really understanding what it is that customers, clients, people who use drugs really want. I think, thinking not just at the most kind of catastrophic end of the spectrum. I think there's a lot of room for other therapeutics.
And really appreciate the flag of the ethics and the component and how we think they're implemented. All right, Phil, you unmuted, and then Karin, I am going to come to you after Phil. Phil.
Right, thanks. For having been doing this for 20 plus years in the communities that we work in and seeing how people have utilized the different ways that we've made naloxone available over that time and gauging their preferences and how they've adapted or not, I'm actually really excited about the swab product. I think that's going to be, if that ever comes into being, that's going to be like our community is going to be able to utilize that really well. I'm also excited about that and potential other products that are bringing the dosage back down, right? I mean, I think that's going to be a big hit also. Again, because, people are telling us they're on, when people are there, when the event occurs and they have naloxone, they're giving them one dose and the person is back up right away, right? And it's when that starts turning into 3, 5, 7, 10 minutes that it becomes really problematic, particularly with fentanyl. I would also like to see, we haven't talked about it much, but a safe way to address benzodiazepines in the mix, something that could potentially work or be combined with naloxone even. Wow, that would be fabulous, right? Particularly since we're seeing, even here in the middle of nowhere, we're starting to see an influx of the IMF benzos, and we're not really sure, where that comes in, and those things aren't even showing up on any standard tests, and so it's really hard to gauge that. But I think also affordable, practical devices to aid in airway management and oxygenation, right? Something that's easier to use than a CPR face mask, but actually does the work. And, as we've been looking for years at the options with those things, we just can't afford some of the cool tools that the EMS folks have and stuff, even a bag with where you pump the thing in, it sits over their face. So somehow making things like that accessible in a way that people could adapt would be really important.
Phil, you said you were excited by the nasal swab. Tell me why.
Again, I just think how I've seen people adapt the different versions of naloxone that we've had, injectable, the atomizers, the the 4 milligram nasal, the Kaleo devices and things like that, I think people are gonna take to that because it's just boom and go, and they can move on to other things. So
right. So ease of use primarily, okay, and as another option. Karin, and then Jesse. Dr. Malley?
Yeah. So I think there's a few things. I think community acceptance is going to be a really key feature. I love the idea of a wearable device that someone could decide to put on themselves to administer naloxone if they begin to have an overdose, or to administer an agent to reverse the respiratory depression. I worry about the acceptance of a device like that and whether or not people would want to use it. Most people of course don't want to die when they're using substances, but they really also don't want to get Narcan. And so I'm not sure if people would voluntarily, I think there would be a concern about, getting naloxone when they weren't, on the when they weren't at risk of having a fatal overdose. From kind of a ideal perspective, I would love to have something that would allow like a more gentle or more gradual reversal, or like almost like a partial reversal that you guys were kind of mentioning already. That was not kind of, because I feel like people right now see that as like almost two, either someone has used a substance and they have, some euphoria and they've gotten high, or they've had an overdose and they need intranasal naloxone. What we really know is there's an intermediate point where maybe they're not breathing quite enough, but they're not apneic. They're not respiratory rate of 0. Maybe it's 8 and it's not enough. And so, something that will allow friends or family members to just reverse them enough that they would keep breathing well, but not so much that people end up, waking up really agitated, or having family members have to worry about blame from their loved one for reversing them, things like that. I think would be pretty powerful.
I'm thinking of the precipice analogy. It seems like the current approach is a really hard yank back, and that we're looking that phrase you had of the more gentle, like the warning of when you're approaching in a more gentle way to pull back. Yeah. Dr. Pines.
Yeah, I'd agree with all that Dr. Malley's just said. I mean, I think what tends to work at scale when it comes to, how do you actually integrate this stuff into, practice at scale, right? How do you actually do that? And what tends to work both in the emergency department and with patients is simple and effective, where you have a very specific protocol where that you can use. And you have, we as emergency physicians, we use naloxone all the time. It's something that's part of the, one of the common meds we use. But the question is, what do you do next, right? And how do you create a protocol that can, reduce the probability that you're going to overdo it and they're going to go into precipitated withdrawal, which when we know that is something we don't want to happen in the emergency department, because that creates major issues for both the patient and the staff, and as well as something where I did see a patient a few weeks ago. We ended up giving him 14 milligrams of naloxone in the emergency department, just barely woke up. He finally woke up. And we realized we actually didn't have enough naloxone in the emergency department to do a drip for him. So once he resedated, we ended up intubating him. So something that they could take on these really more severe, highly potent overdoses, and and the same thing from the patient side. I mean, something that you can give a patient at discharge. I mean, we're discharging these patients every single day after an overdose. If there's one thing that you can give them, and that they could be that could be effective, and we do have some of those tools there. We do have the buprenorphine, we do have the nasal spray. But again, something that fits into the protocol and also fits into the patients in the hospital's budget, that that they're comfortable with us giving out a discharge, because it tends to be a high volume population.
Yeah. Really helpful in kind of the context and thinking through that, and then what are the options in management and then equipping folks with some available intervention after that. Dr. Montoya.
No, I'd like to go back to the comment that Dr. Dasgupta made before about I think that a wearable device that can detect hypoxia, that can trigger like at certain oxygen saturation levels can trigger, let's say, a phone call to a family member, or at the lower level, call 911. I think that's a very, very good, because most of our efforts have been on that patient. As you mentioned, most of the patients that have already overdosed, have respiratory depression, they need a reversal right away. But what if we can intervene just a little bit before that point, when someone just is beginning to have hypoxia, is beginning to feel drowsy, sleepy, and is not in a very severe hypoxic state that requires immediate naloxone to revert. So and that can trigger again a phone call or a way to communicate to bring if it's necessary, administer naloxone. So. And going back to your question, Susan, about the ideal product, I think, the ideal product is a product that will work right away, that will stay for a sufficient time to prevent re-narcotization, and that it does not produce the severe opioid withdrawal. Unfortunately, that product still doesn't exist, but we are yeah. But I think we are in the process of trying to come up to something that will try to. That's the goal. And also with regards to the comment about cost, and we at NIDA, we are very aware that some of those things, or most of those products that are being developed, are likely going to be very expensive. Like, for example, the monoclonal antibodies. But should we stop development because of that? Or maybe we should continue and think in the future, with like COVID, for example, the cost of the COVID test, it went down dramatically in 1 year. So we hopefully, like the development and the administration of that type of product, maybe the price at the beginning will be quite expensive, but maybe with time, the production will be much cheaper, the distribution will be much cheaper, the administration will be much cheaper, and then it can be more accessible to the general communities.
Mm-hmm.
I think that's great, Dr. Montoya. I agree with what you just said. I think there's a lot of innovation that's happening in the harm reduction space right now with devices that are already available. So we see harm reduction programs giving out pulse oximeters that hook up to your phone, paired with canned oxygen. And so we have the rudimentary pieces that we're talking about in a more advanced sensor. That kind of work is already happening on the ground, right? And so I think part of the drug development process is to really listen to the harm reduction programs that are doing this innovation and bringing those like early user experiences into the development process in a respectful way.
Well, and so let me jump on that.
I think
Go ahead.
I think Jessica's the point is exactly that. That's what we need. We need people going to the FDA with those products, or coming to NIDA to seek funding to support that type of products, and then we work with those people and with CDRH to make sure that they go through the regulatory approval pathway,
which is a really helpful way to kind of say, like, here's the research pathway and what we want to pursue, and then here's the regulatory pathway that you can have a coordinated effort there. I want to pick up on something you just mentioned, though, Nab, and explore this. This will have to be our last question because we don't have more time, but I'm going to pull one more piece out from you all. How have people with lived experience been part of the development of these medical products? And if they have not been, or you can't speak to that, how would you like what are some good ways to make sure that we're hearing from people with lived experience?
Yeah, I think frankly, the folks who made naloxone and intervention, who have been systematically excluded and erased from the endeavor of drug development. I mean, if you look at the presentations made by the sponsors at any of the recent AdComs, there's no mention of the history in a meaningful way other than in a self-serving kind of promotional way. So the systematic exclusion of people with the most experience with reversing overdoses is something that has sunk other products that have come to market. And so I think it is in those sponsors' best interest to be engaging in these communities. They are the experts, and they are never treated or compensated in that way. They should be on AdComs as voting members. They should be involved in advisory boards and involved in site selection for those trials. Like, they should be integrated. They're very qualified and they're ready to play that role.
Well, and it would seem you get a level of efficiency, right? In that part of what's essential here is the clinical and the community understanding and engagement for adoption. And so if you built that into your product development, you're ahead on, I would think, you're ahead on the adoption scale.
Mm-hmm. Yep. Yeah, and I mean, even with like the Narcan nasal spray and the development of that when it was still at Light Lake, like there were people with lived experience who were intimately involved in, in the early stages of that drug development process. It's like when the dollars start getting big, people with lived experience get dropped. That's the pattern.
Yeah, and to the peril, right, of those who are dropping it, just again, the pull through in subsequent adoption would be stronger if you have a better understanding. How do we think through, I'd love Dr. Pines and Dr. Malley, a last comment from each of you on how do we do that on the clinical side as well? Are there thoughts you have on how to make sure we in clearly most important lived experience from the patient, but how might we weave in the lived experience clinically as well?
I think that one of the things is that if patients are willing to adapt something, it's a lot easier to use it clinically as well. So, I don't use intranasal naloxone in the emergency department because I have other tools. And I'm only going to do for a patient or provide for a patient something that they're willing to consent for. And so I think that making sure that we are developing things that people want and that would address their concerns is just totally vital.
Yeah, just a last comment. I mean, I think as folks are trying to develop new things that for use in the emergency department in particular, we've got to understand the current workflow for these patients. And, this is a patient population where we do have effective medicines already, right? So if you're going to add something there, there are downsides. We do get, ineffective with reversal, we do get precipitated withdrawal, but for the most part, this is something I've used in more than 20 years of practice, same medicine. So trying to replace that with some new approach in the emergency department really has to have some marginal benefit, and I think really address some of the issues that Dr. Malley mentioned.
Yeah. So not essential then that it's not just molecular innovation, but is it actually helping to change the practice? See, and let me know. Stole that from Dr. Dasgupta. All right. Thank you so much for a fantastic discussion. We're going to move now to our final panel. So thank you so much for joining us. Really appreciate you investing your time. And we'll turn to our final panel, which keeps one of our folks who we had on the last panel, but here we're going to turn to discussing the future directions of research, product development, and public health interventions for preventing and managing fatal opioid overdose. So we have for our final panelists, if I'll have you come on camera if you haven't already, but please join us on the stage. Dr. Marta Sokolowska, who is Associate Director for actually the Associate Director for Controlled Substances and at CEDAR at FDA, Dr. Nora Volkov, who is Director of the National Institute on Drug Abuse, Dr. Ingvild Olsen, who is the Director of the Center for Substance Abuse Treatment at SAMHSA, and then two panelists from our prior sessions. We convinced Phil Feudy from the Mountain Center to stay and do double duty here today, and we will invite Dr. Jermaine Jones from the Columbia University Irving Medical Center to come back. So let's pull the slide down and make sure we have our stage set with all of our participants. So thank you so much for joining us today. I'm just reflecting on all that we've heard in yesterday's and today's workshop. You know, ideas spanned from repealing the Controlled Substances Act, which is outside the scope of any of us here, to doing more to pre-position opioid overdose reversal products, to greatly expanding clinician and consumer education, to improving our drug supply monitoring work and trying to have alternative, cleaner supplies. But you're our regulators, researchers, funders, and providers. From your perspective, how can we ensure that the products that are currently on the market can effectively meet public health needs? So we'll focus first on, we have products, how do we help make sure that those effectively meet public health needs? And I'm gonna go with whoever first raises their hand, either virtually or physically. Who's gonna lean in there and wants to answer that question? All right, Dr. Olsen, go for it.
Great, thank you so much. And thank you also just for an amazing, I was able to listen to some of today's session, and I think you all have brought the right people to the table. It was just an amazing session, also the last one. And, you know, I think one of the things from SAMHSA's perspective and CSAT in particular is that, you know, to your question, so we have, we fund community-based organizations through some grant programs. We fund states through several large grant programs, including the State Opioid Response Program, the Substance Use Prevention and Treatment Recovery Support Services Block Grant, a whole host. You know, Dr. Fan, I think, was on earlier and spoke about some of the discretionary grant programs as well. And in all of those grant programs, particularly kind of on the large state grant programs, that we are really promoting the purchase and distribution and saturation, in fact, of communities and communities where naloxone really is needed with those federal funds. And one of the pieces related to that is we just in January had a 2-day learning collaborative with 50 states, representatives from 50 states and territories, that to really talk about what it is that they are doing, talk about the modeling pieces related to naloxone saturation. And there are some incredibly innovative things that states are doing across the country, and a lot of challenges that they've also have identified. And so we are continuing to work with them, you know, really to be able to help address some of those challenges through technical assistance and training, and really trying to kind of, you know, work through some of those pieces. But it clearly is a SAMHSA, and I would submit, you know, much larger HHS. It's a big pillar of the HHS overdose prevention strategy, aligns with the Office of National Drug Control Strategy. It's a big priority.
And that helps with the confirming. You know, we had a request yesterday to just have it everywhere. Today we got some more texture about what that means to have it everywhere, and to know and get the clarity from SAMHSA that that's part of your effort to assure that we have the product deployed where it's needed. I've got Dr. Volkov and then Dr. Sokolowska.
Yeah, no, first of all, I want to congratulate the FDA. This has been a magnificent meeting, and I actually what it did has brought to my attention is how many issues there is still confusion and how many divergent perspectives there is, which is likely to actually reflect the diversity of presentations and situations that people that overdose find themselves on, including the diversity of drug combinations that are driving those overdoses. And but this is the reality. And on the one hand, we know that we have very powerful tools for reverting overdose. Naloxone works, provided that you give it in time. It will reverse a fentanyl overdose. It's actually, there are issues that will follow depending if you do administer it in time at the adequate dose, but also what support you're going to give that individual. I guess that the challenges comes into how do you implement that, because again, it's easier said than done. And I think that the presentations and bringing in individuals that are taking drugs themselves are actually fundamental, because otherwise we start to think about these very theoretical models that then are not going to be taken by the community because they reject them on the one hand, or are not, the healthcare system is not willing to integrate them. Or on the other hand, as was discussed in the last one, they are too expensive and therefore their utilization is very limited. So from these three perspectives, my view is that our projects, first of all, and the last session said it very clearly, we need to provide multiple alternatives because not one of them was going to be the solution. If you take that in our understanding of pharmacology, that elegant presentations that we had yesterday on showing if you have someone where you are not able to keep the cardiovascular output, then that's a very different situation as having someone that is only hypoxemic. And so the decision of how to intervene is not going to be the same, nor should it be the same, because as we've heard it continuously and repeatedly from patients that have, individuals that have been reversed from overdoses, if they have a very severe symptomatic presentation of their acute withdrawal, they actually will develop a negative condition response to naloxone and actually even to treatment. So they will reject it. So in that respect, I think that the aspect that, and as Ivan was presenting before, the element of the concern that people are not going to be willing to take these automatic detecting devices for an overdose that are going to be administered naloxone, if we turn it around, we may have something that gives us that flexibility. Because if you can actually prevent the advancing of the overdose, you may need a much lower administration of naloxone to enable that person not to go into that collapse of the circulation. So I think that that is an element that we need to speak of, and we are evaluating and we're funding research on that. I think that the other comment that was very clear, we need to bring the individuals that are taking drugs into the game of the products, because otherwise they become just theoretical. And it was interesting to hear that there was a lot of interest on the 10 milligrams vocal naloxone, because in a one way, it is not going to reliably administer the same doses in the plasma, but it may give you a lower delivery system that may be very desirable for someone that doesn't want to go into the full-blown withdrawal. And yesterday we heard the story of this woman who has going into an overdose and doesn't want to take the naloxone, so she takes the buprenorphine, and that allows her to modulate that response. And I think that that's a perfect example, and that indicates why we need more than one alternative. And the other issue, and I do think, I take it very seriously, that complaint. I hate the idea, and I agree with Ivan that we need to push the technology and the science, even if initially it's going to be very expensive, because that incentivizes others to invest. But I also think that we can do for technologies that we already have, we can promote alternatives that become much less expensive, and therefore much more accessible to individuals that would benefit from them. So how do we bring things into the community? We bring them by providing different alternatives. We'll bring them by engaging with them in that developmental process. And we bring them also by providing alternatives that are not going to be so very expensive that they are not sustainable. So this is from the perspective of us as an agency that develops research.
Yeah, well, and I hear and underscore where you captured the idea that we have effective medications, and now as we look for perhaps more that are more nuanced and gentle, and then can be more accepted in the community, weaving in what the community has told us. I want to turn next to Dr. Sokolowska and first say, I completely botched your title, which I know better than to do, so allow me to say we welcome you as the Deputy Center Director for Substance Use and Behavioral Health. And now I'll turn the microphone over to you.
Well, first of all, titles don't matter, but what we do is hopefully matters. And that's what we are here to do. And I just want to say thank you to everyone who was participating in these panels throughout the last 2 days. And Susan, you and your team, you have done a fantastic job, pulling together all the expertise and helping us to understand the ever-evolving crisis. And, I really appreciate some of the comments that are being made about getting engagement of people who are actually experiencing substance use and experiencing the overdoses. And now we do take your comments very dearly to heart. And that's why, we couldn't make the progress that hopefully we have made a progress, at least to some degree, within the last while, trying to increase access to the medication that is already approved, to naloxone. I think it's really critical for us to understand the landscape, right? And that's what this meeting is all about, to truly understand that it's not only opioids as we had before. It's not only the heroin that initially naloxone was developed to reverse, right? It's not 1971 anymore. The landscape has changed. The drugs that are being used have changed. The potency of the drugs have changed. The environment has changed. So this is really critical for us to really understand the current landscape. And as we are collecting additional research, which some of it was presented today, and we really appreciate NIDA partners and others also who provide a lot of that research to better understand how the data is, how the landscapes is evolving, how the new drugs or the old drugs are addressing some of these issues. It's important for us to make sure that, one, we increase access to these medications, right? So we've been, based on the discussions that we had about over a year ago, with harm reduction programs, we have worked on releasing the DSCSA guidelines to increase access for harm reduction programs to naloxone. Again, that's focusing on the increasing access, not increasing cost, but increasing access for those who really need that medication. As we've been very vocal about, we are working very closely, trying to push for non-prescription naloxone. And just recently, we had advisory committee that the experts that we engaged have confirmed that we are on the right path, and we might have a product that might be available for non-prescription, because again, we've heard about it, that it is important that could be the right step to give more access to that medication. But at the same time, we've heard a lot about xylazine, and xylazine overdose, unfortunately, is not going to be reversed as likely by naloxone. So that opens the opportunity for what can we do to really help and facilitate development of new medication, new devices, in order to get something additional to the hands of those who need it the most. And we are looking at any potential accelerated pathways that might be applicable for this space, because one thing that goes without doubt, it's a great area of great medical need. And that's my call, is that we will do whatever we can to help to facilitate, but we can't facilitate, we don't have products on our review. So we are looking forward to learning more, and hopefully the industry is hearing these discussions today, and they will be more encouraged to come up with additional products for our review, and hopefully for patients' access soon.
Yeah.
Affordable patients' access.
Yeah. Well, certainly, I'd say for any members of regulated industry who've been listening, there's been a lot of really valuable information shared about what they should consider in development, as well as what they should continue to consider in deployment of existing products. And so, Phil, I know you had raised your hand on the idea of how do we make more effective use and ensure that the current products meet the public health needs. So go ahead.
Thank you. I personally feel pretty optimistic, about the direction this is all going, in the big picture, and that there is so much attention being paid to these different components, but sort of to build on the idea of involving other people's voices. I unfortunately also believe that the situation we find ourselves in with drugs and the consequences of prohibition are endemic. They're not epidemic, right? From where I've been my entire adult life for 40 years, it's pretty much always looked the way that it does. There's just never been anybody paying any attention to it before. I think what's missing from all of the conversations is that, we're always talking about treating the drugs and not talking about treating the people. Xylazine is a great example of that. It's horrible. I have not heard a single person tell me that it's great, right? And it's made it very clear that we've lost the war on drugs. Like, it's over. We're in the post-drug war phase now. And but when people talk about these things, every time they pop up, the first thing they say is, well, we got to make it illegal. We have to lock up the dealers. Let's bomb the cartels. We need more, all these different high-dose naloxone products. How are we going to treat this? How are we going to, and nobody just asks people, how can we help you? Right? What's going on here? People do say, what can we do about this? Because they don't want to see it, right? Nobody wants to deal with the crisis of homelessness and the crisis of access and the crisis of disparity that we're facing. I think the question nobody asks in looking at figuring out how to confront these things is, what is, for a person who spends their day hunched over, this horrible stigmatizing things that we see every day in the news now, zombies and Walking Dead and all that stuff, right? And people hunched over and their skin falling off. Like, for people, what is preferable about that as opposed to not that, right? Like, nobody ever wants to talk about that the middle piece in all of this. And I think that if, as a country or a society, we are not willing to invest in individuals and communities in any kind of meaningful way, which I don't think we are, no amount of intervention is ever going to have any effect or any change, and the problem's just going to keep evolving with increasingly catastrophic symptoms. I've been doing this kind of stuff for 40 years. Nobody has ever, in the overdose capital of America, nobody has ever come to me and said, what do you need? Right? They're always like, here's this thing, can you use it? Right. And my experience of working in harm reduction is that we're illegal and we claw our way into a little bit of acceptance. And then in order to keep pace, we have to go into the illegal again. And we're trying to get out of that. And during all of that, we're fighting for, basically human rights and dignity for people. The history of harm reduction is one of us that are here on the ground doing these things, constantly fighting to liberate the knowledge and the technology and the money and the things to put it to work in meaningful ways for people.
Phil, thank you for putting voice to, and observing that we, I think societally are going in to solve a problem. You pursue that which you think you can address more quickly, versus, as you've so eloquently stated, the much broader and real, I don't know if it's, I'd say messier, but I don't mean that pejoratively. I mean more difficult, the broader conversation. So I want to say to you, I'd love to hear from you and from Dr. Jones. What do you need? What helps us make a difference?
For me, I would say funding of more implementation research. I think the tools are great. I think we do have to learn how to use them and how to implement them. I trained in behavioral pharmacology, so the importance of implementation science didn't become apparent to me until I moved into from there into clinical trials and then to community-based research. And I think as scientists, we come from a certain perspective, and I in addition to the implementation science, just reiterating the point that a few people have said now of incorporating the target population in our studies. There was a recent trial of a potential wearable device as a part of a clinical trial that I was a part of, and we bring in our first participant, and the first thing he says is, "I'm not going to wear that. It looks like a wire. You're going to get me shot." And those are the types of things that, us as investigators and as scientists, like, I wouldn't have thought of from. So it's a null conversation before we even get started, because those are things that we didn't incorporate and we didn't think of that would have been solved had we asked a single question or did a single qualitative interview before we had this thing developed.
Really powerful example, right? Like it in to the kind of observation earlier, that the people who have lived experience, get left behind. It's at the peril of the developer, right, in missing the mark. Phil, what would you add?
I think that, this was all, it was very complicated at the time, but looking back, 30 and 20 years ago, it was about HIV prevention and fighting to get, among other things, to address that, harm reduction and syringe exchange. I think what's happening, back to my point, and it's become really apparent, and I've been really trying to advocate, like, within our organization and beyond. Our work is becoming less and less about a particular drug or the things that we use for engagement with people. In between 2021 and 2022, we saw over 50% of our participants discontinue injection in favor of smoking, right? And so on one hand, that's a win, for us, harm reduction wise, but unfortunately, and like I said in the previous panel, we're seeing people using naloxone, their doses and things decreasing, and we're seeing the number of people that we provide services to, we're seeing them reporting fewer and fewer overdoses, but the numbers are continuing to go up, which means that must be people that we're not typically engaging. But within that community of folks that, that historically have been more at risk, our work is becoming way more about helping people manage homelessness, nutritional support, medical stuff, hygiene, all of these things, and the supplies that were in the tools and the things are just all mixed in with that. And so once again, I think that we've seen complete failures in our society to address social, economic, access disparities, racism, all the other things that are happening in there. And I feel like it would be really helpful if there was some attention paid to that piece that's in the middle of all of this, because I feel like it's really driving what's happening.
Yeah. I'm going to ask Dr. Olson a question, and then I want to come to you, Dr. Volkov. Ingvild, so in reflecting on Phil's observation about seeing the individual and some of the broader pieces, how does SAMHSA think about that? Is there an opportunity there in how SAMHSA is approaching things to be more about the individual?
Yeah, no, I really appreciate that, and just appreciate Phil and Jermaine your comments as well. So SAMHSA really is taking a throughout kind of all of our programs. SAMHSA, the Assistant Secretary Dr. Delphine Rittman, has identified 5 strategic priority areas, overdose prevention being one of them, but the others are around integrating physical and behavioral health, strengthening wellness and resilience of children, youth, and families, and then a number of different cross SAMHSA principles, one of which is trauma-informed care, using data and evidence, recovery, and really being, I think, kind of whole person centered. And so, because to your point, Phil, absolutely, that naloxone we're talking about naloxone, that is one teeny little piece of a much broader picture, and that in order to help people also be as well as they can be, and be as as healthy as they can be. And in fact, SAMHSA's definition of recovery actually includes 4 domains: health, home, purpose, and community. And I love those, because I think it also just kind of speaks to what people value, and how, and then they get to define kind of what those domains really mean for them. And so across a number of the different grant programs that we provide, really trying to infuse all of those principles kind of within those grant programs, as well as in the technical assistance and training resources that we provide, and all the products and other kind of educational materials that we provide as well. And that includes then really being able to look at kind of unhoused, and how do we support people who have multiple needs, including all those social determinants of health. So I think that's right on, that this is a much broader conversation than it needs to be, because all these different pieces are also kind of intertwined.
Yeah, but really, I think back to Phil, you started with optimism. I'm going to say that there's that response of kind of the SAMHSA looking at the whole person is another ray we can put some optimism in here too, that there's work there, and an opportunity for all of us to be more person-centered. Dr. Volkov, thank you for letting me deviate there to pursue that.
And no, Susan, thanks. And my point was, first of all, I want to again thank Phil for bringing it up. And I think that the message clearly is that we cannot lose the whole forest because of the tree, that it is crucial that we address the issue of what's creating what is called by some diseases of despair, that is driving situations that are making people take drugs and then when they take drugs don't have the support to actually provide them alternatives, because without alternatives, people are not going to change their behaviors. But I think that at the same time, I do see value on focusing on one of the elements that we do have traction, because we are lucky to have a drug like naloxone. And while naloxone may not be the panacea because of the diversity of drugs that are being used with it, and the increasing potency of the opioids that are in the illicit market, they nonetheless provide us a pharmacological agent that is quite effective. Mm-hmm. And so the question to me is, what are the areas? I mean, in listening, I mean, I realize that there are certain spaces we don't understand, including the comment right now that perhaps the increases in overdose deaths are being driven by people that they themselves may not even have an opioid use disorder, but the occasional drug users. And so they are not being reached by many of the support systems that we have. And it is very likely that absolutely they are contributing. What percentage? What percentage of the overdoses, for example, are driven by people that have pain and are seeking out medications out in the web because their clinicians are not providing them, or benzodiazepines? So that is an element. But I also think that we have a lot of opportunity to work together to, again, coming back, say we are giving absolute priority, but we're not speaking about it here because it was in terms of reversal of overdoses, in terms of the implementation science. And implementation science does include models that have maximized the access to overdose. And we've funded the largest implementation study in four states with very high rates of overdoses, where one of the main interventions was education and access to naloxone. And that is a very powerful tool. So, but we need to learn. And what I already learned from that data is that whereas in some states that was very powerful in changing the culture, in others it was not. So coming back to the issue that we're not going to come up with a solution that is going to work for everyone, and that not just relates to individuals, but also to communities and even states, systems that fund certain things or have certain support systems or not. So I do believe that we have to keep in mind and never forget to address what is driving this overdose crisis. But at the same time, I do think it behooves us to dwell into what is it that we can do to make the products for overdose reversal more effective, and to make the individuals that are taking drugs more likely to accept them and to accommodate those products on the basis of the need of the particular individual. So again, trying to realize and personalize those interventions much more than we have done in the past.
Mm-hmm. Really helpful in kind of encapsulating what we need to think about in R, but as we move forward. Phil, I'm going to go to you for one more comment about use of current products. And then Dr. Jones, I want to turn to you to give us a first answer to a question about obstacles to development and how we might address those. So obstacles to developing new products. But Phil, last thought on deployment of existing products.
Yeah, I mean, I really applaud again the move, and I know that Dr. Volkow has been really come out as a really strong, advocating for buprenorphine access, deregulating methadone, being able to drug checking and doing the different things that we can do, and I think that's really helpful. One of the issues, though, again, when we start talking about this thing, I also manage a low barrier buprenorphine clinic, and in a rural community that only has 2 pharmacies that are acceptable to what is largely a lot of people experiencing homelessness in a rural setting, and the pharmacies cannot stock buprenorphine for more than 2 or 3 weeks at a time. And in us trying to resolve that, we've been communicating with the DEA, we've been communicating with SAMHSA, we've been communicating to things. The distributors won't talk to us because of the settlement stuff and all of these things, and everybody's saying it's somebody else's fault and somebody else's problem. And it's really aggravating once again to be in this situation where we are participating and taking advantage in the things that are available, and are continuing to bump up against this kind of issue for which nobody wants to take responsibility for. No.
Mm-hmm. Phil, I think that exposing that type of on the ground reality of you have a population that wants to take buprenorphine and then being able to access it becomes the challenge. That's I don't think the outcome that we're all looking for in the space when you have an interested, engaged, committed individual who then who then is faced with the reality of not being able to actually procure the product that they need. But let's turn to new product development. Dr. Jones, I said I was going to turn to you for some thoughts about illustrating the obstacles that make development of these products challenging, and how can we address them. You already gave us one example with the wire, but other thoughts about obstacles to development and how we might overcome those.
Yeah, in addition, I would say sometimes the pace of science and the pace of research can be frustrating and can make it difficult to feel like you're responding to a current problem. So by pace of research, I mean the time from submitting an application to receiving funding to then having to get an IND or an IDE, and from that time you're 2-3 years into even starting the research, let alone actually conducting the study and getting the results. I think it can make us feel like we're constantly behind, especially when we're trying to address an evolving epidemic, as we've seen with opioid use disorder. So that would be the only thing that I would have mentioned in addition to what I just said about not incorporating the lived experiences of individuals who use substances.
So, short of defying the space-time continuum, which we can't, is it about the urgency on the other side, or is it about thinking through how to streamline and maybe have more collaboration? We heard a bit about the NIDA FDA collaboration, but is it seeing more of that collaboration that would be helpful?
I think that type of collaboration would really help streamline the process for investigators, and I think it would help shorten that the pace of research. Yeah, exactly.
Okay. Dr. Volkov, anything you want to say about obstacles to development and how we might overcome those obstacles?
Yes, I do have a whole list, and we work very closely with the FDA because it's not as simple to develop medications and then get it into the clinic. And there are multiple factors that come into play. So it is crucial. If we don't work with FDA, trust me, we're not going to advance very much. So we work at many different levels, helping grantees and PIs have those interactions, as well as giving suggestions and reaching out to them to get a perspective of how to move things forward. And just in fact, I was actually speaking with Dr. Khalif yesterday morning, asking him, what is it that we can do to accelerate things? So what are some of the challenges? This has been written extensively about, and one of them is that industry per se is not very interested in developing medications for substance use disorder for multiple things. This has sort of got slightly better over the past 5 years, I would say, but still, what it means is that NIDA has to be very creative on the way that what we call the risk compounds, so that then a company can pick them and run with them. And so why is it that companies actually have been reluctant to get into this space? Just like it is for other indications for mental disorders, the successes have been relatively limited and many, many failures. Actually, this is also true for medications for pain. So what we are trying to work with, and again, very closely with for several years with the FDA, that would facilitate, I think, willingness of companies to jump into it and to get more responses, is to look at alternative outcomes that, while not leading to complete discontinuation of drug taking, may nonetheless be beneficial for the particular individual taking drugs. This has been approved for alcohol, but not for any other drug, including nicotine. So we currently are in the process of planning meeting with experts and bringing the FDA to see what would it take for them to consider a particular outcome, in this case, drug craving, that we could use for medication development. And that would, again, facilitate, because achieving full-blown stopping to take drugs is an extremely high threshold to reach. And in fact, interacting with patients who are on medications for opioid use disorder, a very significant portion of them are still taking heroin. So we would have never approved buprenorphine or methadone. So it is crucial that we consider alternative endpoints. And that's where I think, and I do understand where the FDA is coming for. It is crucial for us as a research agency that we can demonstrate that those will be valid outcomes, that they will predict drug taking and they will predict relapse.
Right, that they will make an improvement. And I think that's one where it's been key to have that voice of the individual with lived experience, that, I think using a calculator and looking at it clinically and from a different standpoint, you say, well, of course we want abstinence, but that's from the perspective that's not nearly as helpful or important as those with lived experience. Marta, do you want to pick up on that in the opportunities there and what we can do to address some of those obstacles in drug development?
So a lot has been said already in that space, and we, as it was mentioned, but by night a number of times we are working very closely. And Susan, thank to you and RUF, we had a stimulant use disorder development workshop more than a year ago, and again, it was really critical in understanding some of the endpoints and how can we move it forward a little bit, one step at a time. We haven't solved all the problems just yet. We still don't have stimulant use disorder treatment that is approved by FDA, and it's pharmacological treatment. But we are making steps in trying to understand the science that is needed, and really hopefully provide in the industry some assurance that we are really trying to lean in. And I think that when we show that we lean in, that we really understand the area of medical need, that it's not only a talk, we actually walk the walk. And if you really think about naloxone, when we've been trying to put forward, you really engage with the industry, you really support the access, we see that there is movement and the industry is responding to it. So I am hopeful. Again, I'm not naive that we are going to solve it tomorrow, but there is definitely, the more we lean in, the more likely that there will be research in this space. And frankly, I'm very encouraged by the device space. I think that's an area that is very underutilized at this point, and hopefully we can and really lean into this space and not only focus on yet another pill, which another pill might be extremely important, but really thinking about other opportunities. And just one last plug is that for we have guidances on accelerated approval framework. And I think that really, as in previous meetings, we want to really emphasize that we have various pathways, especially for medication with for diseases with with high medical need that don't have accepted medical treatments, that we can definitely lean in and work together both with our federal partners and with industry to figure out how to smooth the pathway and facilitate and accelerate this development so patients can get this medication.
Mm-hmm. And I think when Dr. Jones said we need things to move faster, he wasn't thinking tomorrow, but the idea to accelerate and collaborate and to use those tools that are available and in working with industry and with the patients. I'm going to turn to Phil, and then I want to preview what I'll tee up as might be our last question, depending on how we approach this. But would love for Dr. Olson and Dr. Jones to think about this. We've said a lot about needing to work with patients with individuals with lived experience. Would love your thoughts on how we might do that. And Phil, I'll let you answer that too. But Phil, why don't you close us out on obstacles to product development?
Yes, thank you. I think that, the very simple thing, and it's a practice that, is incorporated into how, the strategic planning framework and stuff that we do. But, I think, why don't you come out with our program and we'll set up a focus group and people can sit down and talk to people when, whenever we've been able to commandeer some kind of advancement for things, the emotional impact on the people that we work with is profound. And, that several years ago, whenever that was 2015, 2016, that the Kaleo FZO product first came out, and we got a hold of some at one of the conferences where they came and talked to us, and then on the heels of that, the 4 milligram spray came out, and again, I leapt on those based on how people were already using naloxone in the community, and we ran what do you call it? We were one of the few community-based organizations, I think us and North Carolina Harm Reduction, who put those to use and started collecting some data on their use. And I have to say that when, I know our community was not what the people who developed those tools had in mind when they developed them. But when we presented them to people and showed them those things compared to what we had, people cried. They wept and said, wow, I can't believe people are finally thinking about us. And I was, and I'm like, yeah, it's not really what happened, but, but okay. I think that they're having that, when things like that happen, it does a lot. And it's really, I think it's important. I think it would be so great if we had some kind of pipeline for involvement like that, that because of all the other disenfranchisement that I've talked about before, if suddenly this was happening, the impact that it would have on communities would be astounding.
Because it's am I hearing you? I want to make sure that I hear you internalize it, and that I internalize it correctly. That what that experience does is that it then underscores the value of the individual who you serve.
The individual and be able to articulate their experience. Like one of the things that we've done, for instance, people don't want to go to the ER. They'd rather die from a wound infection than go to the ER because of how they get treated, right? And we have brought together the people from our local hospital and members of our community and figured out where some of that was happening, and then to give people the opportunity to express their concerns and things. I mean, so much of, and I think we have to ditch the abstinence thing as a goal altogether. All of these things are all of our ideas about this and treating it and all the rest of that are all molded by prohibition and enforcement, 108 years of it, right? And I don't know, except apart from the battlefield, I ever hear medical people say things like, well, who cares how they feel? We saved their lives, right? We don't hear that in other contexts. And recently there were those EMS people that were arrested and charged with murder because they got called by police to a residence where an individual was in alcohol DTs. And the ambulance, the EMS person walked in and said, I don't have time for this, and had the police carry the individual to the ambulance, and then they strapped him face down so they couldn't breathe. So by the time they got to the hospital, the individual had passed away. Right. So these are the experiences and the things that people have, and that attitude is driven by this overwhelming thing. And I think that by bringing people into the conversation, and particularly around developing things that are potentially resources for them, even if that, naloxone, nobody thought about it going out in the field either when it was invented, right? But our communities have adapted to that really well. And just seeing how people responded when we brought these new, easier to use items to them, or connecting our people with the hospital people so they can learn how to navigate themselves. I mean, we always think of people in experiencing addiction and experiencing these things as people who had something and lost it, and then there's this redemption arc or something in it. And more and more and more, what I've realized is that the people that we're interacting and working with, when you start getting into multi-generational use and criminalization, and multiple generations that have been living on public assistance and things, that people never had a thing to begin with to work with, right? And so it's kind of up to us as providers to be able to pave that road for folks.
Yeah. Thank you, Phil. And Marta, I'll turn to you, and then Jermaine and Ingvild, just a heads up that I'm going to come to you with ideas on how to engage with individuals with lived experience in this space. Marta.
So I just wanted to highlight the fact that how important it is for us to work with patients or people with lived experiences through patients' drug development meeting or meetings as we have today, and emphasize that abstinence is not the endpoint for our drug development program. We understand that this is not the goal for some of the patients or most of the patients, and we want to make sure that it's really clear, loud and clear, that we are really open to understanding what endpoints matters, functional endpoints particularly, that we can incorporate that into drug development programs. So these sometimes are not the easiest endpoints to demonstrate, but we want to make sure that it's truly loud and clearly identified that abstinence is not the only abstinence endpoint, because we understand this is not aligned with patients' goals.
I think we know from other discussions that that's often something that people misunderstand about the FDA's standard and approach in this space. So the more that we can help clarify that, in fact, that is not the standard that the agency is looking for. Okay, Nora, I'll let you go.
Let me ask, because I do want to basically, this is what we're trying to get, an agreement that we can use an alternative outcome that is approved by the FDA. Currently, as I say, the only one is for alcohol. But right now, for all of the medications that are up, that actually we are developing for opioid use disorder, we need to show that there is abstinence of certain percentage of patients over a certain period of time. So am I listening wrong, or this is where we want to go, or what is it exactly? Because I think it's important to clarify. I would love if we can get an alternative of reduced drug use, for example.
And Nora, thank you for pointing it out. And as you see, and from our guidance, final guidance on endpoints for opioid use disorder treatment development, we do focus on other endpoints such as reduction in use as one of the outcomes. So definitely that's something that we are very much open to exploring and supporting that research.
But you're saying as one of the outcomes, can it be the main outcome?
We can definitely discuss, and we do see the value, yes.
Yeah. And in fact, am I right, Marta, that the responder definition for the last several products that FDA approved for opioid use disorder, it was not full abstinence? It was a different response that was measured?
I would have to go back to see specific applications, so I don't want to provide definitive answer on that. But my understanding is that the reduction of use, with well-defined what is the reduction of use, that is the key, that we need to have clear definition of what is the reduction of use and that it leads to meaningful functional improvements. We don't want to just see some reduction of use doesn't lead to an additional functional improvement. That is really key. But it's my understanding that we've been open to it.
Let me jump, and I'm terrible, and I apologize, but because I am so passionate.
Last time, that's okay. Go ahead.
And I think the notion is how we define reduction in use, right? So you can define reduction in use. There's no use over 2 weeks, for example. But say, for example, that I am a cocaine user and I go into a binge of 24 hours and I am taking a medication that actually reduces that need to escalate. So I only take it for 1 hour, but my urines are going to be positive. So I'm not going to go into a negative no urine that day. So I think that is the aspect that has become much more complicated, where we are finding actually this difficulty that we are defining reduction in drug use by the number of days that the person has a negative drugs in the urine. Whereas the argument is, if you can reduce the total dose that someone consumes, that could be beneficial. But I guess this is a little bit of the nitty gritty, and I don't want to be so terrible, because I do think that we are in this type of forum to push the envelope, to try to get back and forth.
Absolutely.
Yeah, thank you, Nora. And just if I could just mention one thing, as you know, Brian Killick, that is very much supported by NIDA, is working on development and validation of number of these endpoints, including reduction in use, that do seem to be appearing to be linked with functional improvement. So we are very excited about it. Also, he's looking at DSM-5 criteria, for instance, and how there are patient-reported outcomes that could be associated with improved functionality in that space. So again, I think there is a lot of hope. Some more work has to be done. I agree with that. And you mentioned craving, which is another area which I know there is some research. And I know, Susan, you are praying that we are finished. So I'm just going to say that we understand that there is a lot of need, and we are looking forward to working together on addressing it, both with SAMHSA and the patients and NIDA, to really have common understanding of where we need to go and what other data do we need.
Awesome. So I am going to give Dr. Jones and Dr. Olson the last 2 opportunities to speak. And I want you to cover 2 things. One, what are good ways to reach individuals with lived experience in order to incorporate them? And then what's an area of hope that you have in this space? So Dr. Jones, and then we'll close out with Dr. Olson. Dr. Jones.
I would say, as far as ways to engage people with lived experience, I'm a fan of community partnerships, community advisory boards to help with study development. Also think it's great to get the convergent expertise of investigators and harm reduction practitioners in the same room. Harm reduction practitioners are out there saving lives. So, documentation and, filling in numbers and reporting, that's not what they do, but that is where I can help and where I can do some things and learn from the great work that's being done to then get that work disseminated. I'm also, I'll give a plug to qualitative interviews as well. It may seem like they don't have a place in med or device development, but I think we're finding that just 20 or so qualitative interviews can really inform clinical trials to a great extent. As far as the next question, which was an area that I feel hopeful for, I would say overall in the years that I've been doing this work, I've seen sympathy for people who use substances to have really increased dramatically among the general public, and I hope that trend continues. I know that there is a lot of fear, particularly surrounding fentanyl and its analogs, and because there's so much fear surrounding this, it has the potential to antagonize a lot of that sympathy that we've developed over the years. And but I would say that I hope that trend continues.
Well said, Dr. Olson. Last word on engaging individuals and an area of hope.
I think on engaging individuals, I would also echo Dr. Jones, but I would add that being very intentional about really making sure that whether it is through hiring practices, advisory boards, steering committees, SAMHSA had a harm reduction steering committee to really provide those voices of people with lived experience, and doing that at every step, because that is having people being able to safely share their voices in spaces where it's really listened to, and where it is okay to be open about the fact that somebody has a substance use disorder or is using substances. And I think that is an incredibly powerful narrative, and that the stories that people tell, and when you put a face and a name to a story, it becomes human, as Phil was talking about. And I think that the one thing that I'm hopeful for is just that. And this, I think this conference, the fact that there have been panels with, lots of different voices, lots of different perspectives, in an area where perhaps it's complicated, but the fact that we're kind of all together, and I think to Dr. Jones's point that we have an incredible opportunity now in this country to make just some really significant strides in the lives of people and their families and communities, and I'm hopeful that we're going to continue kind of in that direction, and really being able to kind of save lives one person at a time. As a provider, I see patients every Friday morning still, and the reward of really being able to actually walk through the journey of someone who and be there and be supportive no matter what, without judgment, without stigma. It's human. We're humans. So connecting that way is really just incredibly rewarding.
Fabulous words to close us out. And so I'll just say thank you to our current panelists, to everyone who's joined us to speak, to contribute, to listen yesterday and today. The investment of your time is extraordinarily powerful and helpful. We will be posting the recording and other materials for this event on the Foundation website by next week. But thank you so much for all that you do in your day jobs and for taking the time with us in the last few days. Take care.